everyone to meeting number 38 of the House of Commons Standing Committee on Health. The committee is meeting today to study a number of matters relating to the emergency situation facing Canadians in light of the COVID-19 pandemic. I'd like to welcome the witnesses. With the Canada Border Services Agency, we have John Osowski, President. We have Denis Vinette, Vice President, Travelers Branch. From the Department of Health, we have Dr. Stephen Lucas, Deputy Minister. From the Department of Public Works and Government Services, we have Mr. Bill Matthews, Deputy Minister. From the National Advisory Committee on Immunization, we have Dr. Matthew Tunis, Executive Secretary. From the Public Health Agency of Canada, we have Mr. Ian Stewart, President, and Dr. Teresa Tam, Chief Public Health Officer. We'll start with our statements from our witnesses. We will start with Mr. Osowski, please. 5 minutes.
Good morning, Chair. Bonjour, Monsieur le Président et membres du Comité Permanent.
Good morning, Mr. Chair and members of the Standing Committee on Health. I'd like to thank you for having invited me to participate in the discussion today.
I'm pleased to be here to respond to your questions about how the Canada Border Services Agency is implementing and enforcing border measures during the pandemic. I'm here with Denis Vinette, Vice President of the Travelers Branch at the CBSA. Since the start of the pandemic, the CBSA made its pandemic response a priority. To help keep Canadians safe and protected, the Government of Canada has put in place emergency border measures to limit the introduction and spread of COVID-19 and its variants in Canada. CBSA Border Service officers apply over 90 acts and regulations to safeguard Canadians. And over the last year, we have also implemented the provisions of 50 orders in council that apply to foreign nationals and residents of Canada. The OACs are designed to restrict travel and establish public health requirements so that we can reduce the spread of the virus into Canada. The measures have resulted in 96% less air traffic and a 90% drop in non-commercial traffic entering Canada by land compared to pre-pandemic volumes. It's important to point out that Canadian citizens, permanent residents, and people registered as an Indian under the Indian Act have a right to enter Canada. However, all travelers seeking to enter Canada go through enhanced screening measures by CBSA Border Service officers and must meet testing and quarantine requirements to keep Canadians safe unless they qualify as exempt. Of course, some cross-border travel is necessary to maintain the flow of goods and services critical to our economy and our people. The majority of individuals crossing in vehicles at the land ports of entry are essential service providers such as truck drivers and nurses. We must continue to strike a balance between keeping Canadians safe and keeping the economy running. Data shows that Canada's pre-arrival, on-arrival, and post-arrival testing requirements and quarantine requirements are working. For example, over 99% of travelers entering Canada have either complied with the pre-arrival testing requirement or were exempt from it. The CBSA continues to work with other Government of Canada organizations on the pandemic response. Our agency works in close cooperation with the Public Health Agency of Canada to implement and uphold the public health measures that are recommended at the border. The last year has shown the CBSA is able to rapidly adapt its operations to put new processes, rules, and orders in place. We are certain we will be able to continue to respond to new and evolving measures, including the potential use of proof of vaccination credentials to facilitate travel and manage the border. Mr. Chair, since the beginning of the pandemic, we have supported the government's efforts to establish strong measures to secure Canada's borders and to help prevent further introduction and transmission of COVID-19 and its variants into Canada. We have demonstrated our resolve and willingness to adjust restrictions based on scientific evidence. I'm very proud of the work the CBSA officers have done and will continue to do to protect Canadians and the Canadian economy in the face of this pandemic.
It will be my pleasure to answer questions from committee members. Thank you.
Thank you, Mr. Osowski. We'll go now to Dr. Lucas, Deputy Minister. Please go ahead, 5 minutes, please.
Thank you, Mr. Chair. It's my pleasure to be here along with colleagues from CBSA, PSPC, Public Health Agency of Canada, and NACI. Mes remarques aujourd'hui porteront sur les
My remarks today will focus on the actions that Health Canada has taken to keep Canadians safe during this pandemic. Health Canada is the regulator for health products, including therapeutic products, vaccines, and medical devices. Our scientists review health products for their safety before they can be sold in Canada.
We recognize the need to facilitate the authorization of COVID-19 treatments and vaccines, given that in the early stages of the pandemic, none were available. Health Canada has expedited the review of COVID-19 clinical trial applications, treatments, and medical devices through the use of interim orders so that Canadians have access to the products they need to keep safe. We have authorized 265 disinfectants, more than 4,500 hand sanitizers, 645 medical devices, and 2 treatments. In the context of treatments and vaccines, rolling reviews permitted manufacturers to submit their requests for authorization before they completed all the clinical trials, allowing Health Canada to evaluate the data of promising candidates as it became available. As you know, Health Canada has authorized 5 different COVID-19 vaccines. Ongoing monitoring of the safety and effectiveness of these vaccines is a priority for Health Canada. We also require evidence of product quality before each lot of vaccine is distributed in Canada. This is true for the Janssen vaccines received on April 28th that contain drug substance that was manufactured at the Emergent site in the United States. Health Canada continues to work closely with Janssen and our international partners, including the United States Food and Drug Administration, to confirm the quality of the supply, given the issues reported by the US FDA after its inspection of the Emergent facility in April. Let me take a moment now to say a few words about testing and screening, which, along with public health measures and vaccines, help to slow the spread of COVID-19. As of May 15th, the department had approved 68 test kits, including 17 rapid tests. More than 27 million rapid tests have been shipped to the provinces and territories. In addition, as of May 18th, the Government of Canada has provided almost 1.5 million rapid tests directly to private and not-for-profit organizations in critical sectors across the country. These rapid tests used in screening programs can help to identify pre-symptomatic and asymptomatic cases so they can be isolated early to help stop the spread of COVID-19 in workplaces and other settings. As vaccine rollout continues, testing and screening remains important in protecting public health and supporting reopening. Plus que jamais, les Canadiens ont besoin de
More than ever, Canadians need access to virtual healthcare services.
of virtual care in Canada, which will help reduce the pressure on health systems and provide Canadians with needed health services and authoritative information in a safe and secure manner through telephone, text, or video conferencing, in addition to face-to-face visits. In May 2020, the government announced an investment of $240.5 million to increase access to virtual services and digital tools to support Canadians' health and well-being. $150 million of that funding is being provided to provinces and territories through targeted bilateral agreements. In addition, Canada Health Infoway will receive an additional $50 million to support provinces and territories in their efforts to implement these new virtual health initiatives and work with the Canadian Institute of Health Information on content standards for virtual care. In conclusion, we continue to work closely with provinces, territories, and other partners to adapt to the challenges of delivering healthcare during the pandemic. I look forward to answering your questions. Je serai heureux de répondre.
I look forward to answering your questions. Thank you.
Thank you. We'll go now to Dr. Tam. Dr. Tam, please go ahead. 5 minutes, please.
Thank you, Chair and members of the Standing Committee on Health, for inviting me to speak to you today. The Government of Canada has taken a whole-of-government approach to the response to the COVID-19 pandemic. Every day, we are achieving important milestones in Canada's vaccine rollout. In just 5 weeks, we have doubled the number of COVID-19 vaccine doses given across Canada, from 10 million doses administered by mid-April to almost 20 million doses administered to date. And as of May 15th, 55% of eligible adults have received at least 1 dose of COVID-19 vaccine. As outlined in Canada's COVID-19 immunization plan, the goal throughout our campaign has been to enable as many Canadians as possible to be immunized as quickly as possible against COVID-19, while ensuring that high-risk populations are prioritized. In doing so, we will reduce serious illness and death while minimizing societal disruption. To meet these goals, we have conscientiously relied on the accumulating scientific data, the emerging evidence, and the guidance of public health experts to inform our decisions, strategies, and recommendations. The Public Health Agency of Canada's Vaccine Rollout Task Force has been guided by committees of immunization experts, such as the National Advisory Committee on Immunization, and through close collaboration with provincial and territorial partners. Grounding our approach in public health science and equity resulted in the identification of priority populations and the extended dose strategy currently in place. These strategies have been instrumental in meeting our public health goals and maximizing protection both for at-risk groups and the population overall. Although the national daily number of COVID-19 cases remains high, as we continue to feel the effects of a variant-driven third wave, there is reason to be optimistic as public health measures are demonstrating an impact and vaccine coverage broadens. Over the past 7 days, there's been a more than 25% decrease in daily cases, and compared to last week, the number of patients in hospital has dropped by 10%. Nationally, deaths have decreased by 15% compared to last week. The success of vaccinating priority populations first, specifically people 70 years of age and older, and those living in congregate settings, is borne out by the observation that this age group has the lowest case rates nationally, and its hospitalization rate is also decreasing. While nationally all age groups are seeing a decline in case rates, people aged 20 to 39 years now represent the highest rate of infection. As additional age groups become eligible to book vaccines in different jurisdictions across the country, this highlights the importance of everyone stepping up to get their shot as soon as it becomes available to them. We are committed to removing barriers to vaccination and building vaccine confidence. The success of the vaccination campaign relies on as many people as possible taking part. We are broadcasting this message loud and clear through the nationwide Ripple Effect communications campaign launched this week, which uses multiple mass media formats to encourage vaccine uptake. I myself am reaching out to key priority groups, such as personal support workers, and key influencers, such as faith leaders and YouTube personalities popular amongst younger adults. The good news is that a strong majority of adults in Canada have indicated intention to be vaccinated. However, despite this encouraging finding, we know that we must sustain our pace of vaccination even as coverage rates climb. As case rates come down and there is a pressure to release health measures, there remains a risk that those who face barriers to accessing vaccine be left behind. In this regard, community-based efforts to encourage vaccination will be crucial in the coming months, and we know from experience that these approaches are effective. For instance, we have seen positive results in vaccine uptake using approaches that engage Indigenous leaders and supporting, for instance, urban vaccine clinics operated by Indigenous organizations. And we have seen success in reaching racialized and marginalized communities with information about vaccines by engaging individuals in their own languages and on platforms that they already use. Through dedicated funding, we're doing more to support the efforts of those with the expertise and capacity to promote vaccine confidence in their communities, especially in those communities experiencing health and social inequities or that have been disproportionately impacted by the COVID-19 pandemic. The Immunization Partnership Fund has provided $3 million per year since 2016, supporting 22 projects to increase vaccine uptake. In 2020, an additional $30.25 million was confirmed to fund more than 100 projects focused on capacity for healthcare providers and community-based programs, specifically social media campaigns, targeted resources, and frontline interventions. The Vaccine Community Innovation Challenge, funded with $1.5 million, supports projects in diverse communities to help spread the word about vaccines, increasing vaccine confidence through creative, community-driven, and culturally appropriate means. There is reason to be hopeful as we begin to feel the impacts of widening vaccine coverage across Canada, but we're not yet in the clear. Long-range modeling suggests that new cases will continue to decrease if current measures are sustained. We have an important window of opportunity to bring COVID-19 under control in Canada very soon, but it requires two key actions. First, getting vaccinated as soon as it is possible to do so, and second, continuing to follow public health measures until it is truly safe for them to be relaxed. These two elements will provide the vaccination campaign the environment it needs to yield the highest possible results to protect Canadians and support the reopening that we're all so eagerly awaiting. Thank you.
Thank you, Dr. Tam. We'll start our questions now. We'll start with Ms. Rempel-Garner. Ms. Rempel-Garner, please go ahead, 6 minutes.
Thank you, Chair. I'll start directing my questions to Mr. Stewart. On what date did you become aware of the allegations against Major General Danny Fortin?
Mr. Chair, honorable member, there are two elements to that question. I first became aware that there was some issue in the third week of March, around about. And then the specific allegation moving into a process, I became aware on May 13th.
Thank you. On what date did you first discuss or correspond with the Minister of Health or any staff within her minister's office regarding the allegations against Major General Fortin? Was going on in March, and you had no correspondence with the minister or any of her staff?
I did not.
Until May the 13th.
Mr. Chair, honorable member, that's right. I did not raise the March understanding. It was unclear what exactly was involved, so I did not raise it with the minister.
Who made you aware of this issue in March?
March, the Deputy Minister of National Defence.
What was described to you as the issue at that time?
That there was an issue affecting Major General Fortin, but the nature was not apparent, and that was just a kind of a heads up that there was a potential issue.
Was the potential need to replace Major General Fortin discussed at that time?
No, we did not discuss that at that time.
At what point was the need to replace Major General Fortin discussed?
May 13th is when we decided that there needed to be a change.
Mr. Stewart, did you ask any other questions of your colleague in National Defence after first being made aware of this allegation in March?
This is an area that involved some kind of situation that would pertain to personal information around that person. And also it was regarding a serving member of the Canadian Armed Forces. So it's not a space that the Public Health Agency would get involved in.
Did anybody suggest to you between the time you were first made aware and May 13th that Major General Fortin may need to be replaced?
Well, I certainly began thinking about if there is some incident, what would it entail? That's, I guess, kind of my response was, yeah.
Did you share those concerns with the Minister of Health?
No.
Why?
No, I did not. Well, it's an operational matter. The personnel at the Public Health Agency of Canada and the teams involved are under my responsibility.
Did you have any concerns that an undisclosed problem with the person in charge of Canada's vaccine rollout may be problematic?
Well, as I said, I began to think about it, but at that time, it actually wasn't clear what we were dealing with.
Did you press for any more information between March, that when you were made aware, and the end of May?
Who pressed for information from?
You. I mean, did you do anything to get more information to understand how this might compromise Canada's vaccine rollout?
We have a highly effective and well-performing team that involves over 200 people doing the vaccine rollout. And we have a variety of executives leading that team, including 2 ICs, et cetera. So the vital mandate of the vaccine rollout is taken extremely seriously by this organization. At that stage, potential issue was not clear what it was, and nor was it clear what the repercussions were going to be.
Did you discuss this issue with anyone in the Privy Council office or any other minister's office or the Prime Minister's office when you became aware of it in March?
As I mentioned, when I became aware of it, I did not discuss it with the minister or with the minister's office, nor, of course, would I discuss it with the Prime Minister's office.
Okay, and there was no one else you discussed it with beyond the person who made you aware of it in March.
Do you mean within my organization, or what do you mean?
Sure, I just want to know who knew, essentially.
Well, I have a
once you
chief
became
of staff. I have a chief of staff, for instance. I would have discussed it with my chief of staff just as an issue that we were thinking about.
Okay, thank you. Mr. Stewart or Dr. Lucas, by what date do you currently expect 20% of Canadians to have received both doses of vaccine?
Sorry, Steve, are you going to answer that, or do you want me to?
You go ahead, Ian.
We're trending well towards late June that we would make an achievement of that nature.
Thank you. What date do you expect to have about 50% of Canadians receiving both doses of vaccine?
Both doses of vaccine, so 2 doses, I think would be something that we would be achieving in July, the back end of July, August, and around there.
Thank you. My last question, Mr. Stewart, do you think that not acting on a potential allegation of sexual harassment might send out the wrong message to women in your department as well too? I'm just kind of flabbergasted that you would know about this in the middle of March and not do anything about it.
I can't be more clear than possible to say I did not know that there was an allegation of a sexual nature. There was a potential issue. There was no allegation. You're using the word I knew about an allegation. There was an issue, and I was aware that there was an issue, but the exact nature was not specified. We did not have an allegation.
You didn't think that, like.
Thank you. Thank you, Ms. Rempel-Garner. We go now to Ms. Sadhu. Ms. Sadhu, go ahead, please, 6 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being here today, and thank you all the hard work you are doing on the front line. So my first question is to Dr. Lucas. Dr. Lucas, while PCR tests are the gold standard, rapid tests are an important tools in our arsenal. And so far, the federal government has provided millions of rapid tests to provinces and territories. How many rapid tests have been procured for the provinces and territories, and how many for Ontario?
Thank you, Mr. Chair, for the question. As I noted in my opening remarks, the federal government has procured and shipped approximately 27 million tests rapid tests to the provinces and territories. In regard to the specific number for Ontario, I'm just seeing if I have that number at hand here. But let me, I'm just looking here, approximately 11 million for Ontario.
And to follow up, what role can rapid tests play in certain high mobility setting, and how can provinces and territories use them effectively?
Rapid tests have been demonstrated to be useful in regular serial screening of people, as well as in helping in settings where there are outbreaks for rapid screening and followed by confirmatory PCR testing. For example, the government of Nova Scotia has used them effectively in settings in downtown Nova Scotia, for example, in downtown Halifax, forgive me, for example, as for patrons of restaurants and bars in terms of rapid screening, and have used them through the wave that they've been experiencing over the past several weeks.
Thank you. And next questions to Dr. Tam. Dr. Tam, you talked about community-based approach. I'm from Brampton in Peel region. About 60% of the adult population has received a first dose, and it's now being made available to anyone over the age of 12. The vaccine has been made available through alternative clinics, such as one targeting specific culture groups for those that go into high-risk workplaces. Can you speak to the importance of these alternative clinics in the efforts to reach all population?
Yes, it is really important to use every method available And at this point in time, when vaccines are now being essentially provided to all eligible groups in many areas of Canada, I think having more targeted approaches that really means listening to the community and what their needs are is very important. Some of it will necessarily come from providing more information to individuals, but a lot of it is about trust. So having community leaders, having the language supports, having these clinics that open during all night and all hours, it's really important for access purposes. So I do think that all of these efforts combined are really important. And as I mentioned in my opening remarks, some of the key target groups will be younger adults and workplaces, and engaging the private sector to see what more can be done to encourage vaccine uptake are some of the examples. I think that our best practices, I think that can be transferred across Canada. So our vaccine community innovation challenge has been really very, very popular, and these are projects supporting diverse communities like the ones that you've just talked about. I'm actually really optimistic, and I think with everybody's support, including community groups, we will get there.
Thank you. Next question to Mr. Matthews. The government said back in December that every Canadian who want a vaccine will be fully vaccinated by September. How many doses have been advanced so far, and how many people have been vaccinated? Do you believe we are on track to meet this goal?
Thank you for the question, Mr. Chair. I think I can speak to procurement of vaccines, but actually in terms of questions of rollouts, that's probably a better question for my colleague, Ian Stewart, in terms of on track on the rollout.
Regarding vaccine rollout, we definitely are on track, and thank you for the question. In fact, we just clocked 20 million doses, I think in real time during this proceeding today, have been administered. There's always a bit of a difference between what we've distributed to the country, which is about 23 million doses, and what the provinces and territories have been able to organize and line up the appointments and deliver. And they just hit 20 million doses for Canadians. And that takes us to about 48% of Canadians have now received their first dose. So the vaccine rollout is a huge effort, and the provinces and territories are, of course, doing much of the delivery work, but it takes a large collaborative team, and we're very pleased with the progress being made.
Thank you. And how does Canada compare to the United States and to other comparable countries in G7 and G20 in terms of vaccination rates, to Dr. Lucas?
Thank you, Mr. Chair, for the question. Canada's rate of administration on a per capita basis is certainly significant at this point. For first doses administered, we're at about the same level of the population having received it as the United States.
Thank you, Mr. Liu. Nous allons maintenant à Monsieur Thériault.
We now move to Mr. Thériault. Go ahead, Mr. Thériault. 6 minutes, please. Thank you very much, Mr. Chair. My first question will be for Dr. Lucas. This week, we learned that Health Canada, as in Europe, had authorized storing Pfizer and BioNTech in the fridge at normal temperatures for 31 days. To date, the recommendations were to keep it at -60 to -80. So that's great news. First, I'd like to know what has changed. Why can we now do that? And then please explain how that will have an impact and how it will accelerate vaccination. Thank you.
Thank you, Mr. Chair. So as the honourable member noted, indeed this week Health Canada authorized the submission of Pfizer to extend the period in which the vaccine could be stored subsequent to thawing in a refrigerator between about 2 and 8 degrees Celsius to 31 days. It had been previously authorized for 5 days in refrigerators. Pfizer has gained experience through their work initially with the ultra cold storage, and then for a period of time at minus 20, and now to be able to store it for up to 31 days in refrigerators. This will enable a broader utilization of Pfizer. I'll make a few comments and then turn to Ian Stewart for any further comments, given the Public Health Agency's responsibility for vaccine rollout, but it will enable broader use of the Pfizer vaccine in settings such as pharmacies or in the territories, as well as in settings such as physician family practice clinics. Mr. Chair, I could turn to Ian Stewart for any further comments.
Well, thanks for that, Steve. Oh, sorry.
Quickly, since I have a sub-question, please.
Okay, well, I would just say that it's actually very empowering and enabling for the distribution of Pfizer in a much more distributed way. So we're very excited about it, Mr. Chair.
Bon, on a beaucoup fait.
We've talked a lot about the diversity of the vaccine portfolio for Canada. Now, we can have access to settings we couldn't have access to before with the mRNA vaccines. Do the other vaccines not become secondary at this point? Why not just set them aside first and second now, to whom it may concern? Regarding our reservations, could we say, thank you, but no thank you, we don't need your vaccines, without it costing us a fortune?
So, Mr. Chair, I may turn this question to Ian Stewart and Dr. Tam for responding. Health Canada's approved 5 vaccines, as I noted in my opening statement. I'll turn to Ian and Teresa on rollout and advice.
Okay, well, thank you for that, Steve. Mr. Chair and Honourable Member, the portfolio approach that we've taken has proven robust. A number of the vaccines we were hoping would be part of our immunization campaign have had challenges, sometimes in production, sometimes in their approval. And so the net result is that we've ended up with a couple vaccines that are playing a very foundational role. As you would know, both Pfizer and Moderna have been a major part of what we've done, as well as AstraZeneca to a lower level. So having that diversity of options, in fact, has been very beneficial for the country, and therefore I think the portfolio has been quite advantageous. With respect to the difference among them or the qualities.
Excuse me, it's been advantageous when there was a shortage, but now that we're able to have what we need to vaccinate people with vaccines that don't have adverse effects like AstraZeneca's. So there's already an issue with Johnson. So why continue with that unless we think there's going to be a shortage with Pfizer-BioNTech? Now that we know we can deploy them, I don't see why we'd expose people to thrombosis. There's already been 4 in Quebec.
Well, thank you. Mr. Chair and Honourable Member, your question itself reflects the progress that we've made as a country in our national immunization campaign. Getting sufficient doses in order to address the public has been the key priority. And we are now reaching a point, and the National Advisory Committee on Immunization advice reflects the point that you're making. I'll turn to Teresa. Dr. Tam, maybe you'd like to talk to the topic.
Thank you. So, Mr. Chair, I think we are at a turning point for sure, given the supply, that the vast majority of vaccines will be, I think, a Pfizer vaccine, but having a diverse portfolio as a backup option is always a good idea. With the AstraZeneca vaccine, the provinces, territories have chosen to pause on giving any more new doses or first doses, but we do need additional supplies, which we have for the second dose for people who wish to take the AstraZeneca because they started on that schedule. And as you probably appreciate, that there are data that we are still looking at on the mixed schedule, and the National Advisory Committee on Immunization, once they have that data, will be able to provide a recommendation to determine if the mRNA vaccine, such as Pfizer, is suitable for that second dose. After that, there still needs to be some backup options for people who might be allergic to the mRNA vaccines or for some other reason can't take it. So it's still important to have some diversification in our approach.
Merci, Monsieur Theriault.
Thank you, Mr. Theriault.
Going now to Mr. Davies. Mr. Davies, go ahead. 6 minutes, please.
Thank you, Mr. Chair, and thank you, the witnesses, for being here. Dr. Tam, can a partially vaccinated individual transmit COVID-19?
The data is still accumulating. Some studies have shown that even with one dose, there is a reduction in transmission to others. But it won't be 100%, nor would it be that even with 2 doses. But I think the data is trending in a very positive direction. So if I would just sort of clarify that, of course, if you prevent infection, symptomatic or asymptomatic, you will reduce transmission. And so that's one thing. And that those vaccines, even after 1 dose, has had a very high vaccine effectiveness, particularly against serious outcomes. So that's very positive. And I think one study, for example, from the United Kingdom demonstrated a sort of 50 to % or so reduction in transmission, or 50 to 60%. But overall, even with 1 dose, I think we expect to see that effect.
That's a long answer to an answer that I think is a partially vaccinated individual can transmit COVID-19. Would that be a correct statement?
We believe that would be a correct statement.
Okay,
and
thank you.
Of course, even a fully vaccinated person have a much reduced risk, but there is a potential.
Thank you. I'm not sure to ask this question to Mr. Stewart or Mr. Osowski. How many doses of the AstraZeneca vaccine are currently sitting in Canadian freezers?
So, Mr. Chair and Honourable Member, it would be me, I think. Remember, Honourable Member, we just received a shipment of 655,000 doses of AstraZeneca, and those are only being distributed over the past week. So a lot of them will be in handling and storage for further distribution onward. So the answer, I guess, is more than 655,000 to the extent that the province has had a few left over from the previous shipment.
And do you expect that all of those doses will be administered, or will some be allowed to expire?
I think nobody wants to have any doses expire, and I think the provinces are very conscious of the fact that there's a need to get them into use. But I think I would go on to add that I think the provinces, as Dr. Tam mentioned, are beginning to move away from first doses of AstraZeneca and towards second doses, and so I think there's going to be a bit of watching this space. And as you probably know, the National Advisory Committee on Immunization is also looking at the idea of mix and match, where instead of a second dose. Oh, sorry.
You anticipated my next question, which is:
Sorry.
Is NACI planning to issue guidance on dose mixing for Canadians who received the AstraZeneca vaccine as their first dose? And if so, when can Canadians expect that guidance will be issued?
Okay, sir. Maybe Teresa, I could turn over to you on this topic.
Mr. Chair, can I have my time halted, please? I'm not sure who's waiting to answer. Dr. Tam, are you going to answer that question? I can't hear Dr. Tam.
Dr. Tam, you appear to be muted. Actually, you're now muted.
Yeah, so sorry, can you hear me now?
Yes.
So the evidence that NACI is waiting for is likely to be available by the end of May. So we expect a recommendation around the first week of June on mixed schedule.
Okay, thank you. Mr. Ostowski, why are hotel quarantine requirements on international travelers applied to people arriving by air, but not international travelers crossing the border by ground?
Thank you for the question, Cheryl. I think, first of all, it's important to understand that however you come across the border, the perimeter and the quarantine and all the pre-arrival requirements apply. So you still have to have a PCR test. You still have a day 1 test on arrival. You still get a day 8 test. You still have quarantine requirements. So in terms of the pure GAA phenomena, the reality is we've got 117 land ports of entry, and there just simply isn't the hotel infrastructure available to potentially service all of those that would cross the land border to put in a GAA type situation. And so from that perspective, we've been relying on our perimeter controls to great effect.
Okay. And you do realize that there have been tens of thousands of travelers who have diverted their plans in order to escape the hotel quarantining by simply changing their flights to land in U.S. border towns and crossing by vehicle. You're aware of that phenomenon?
Yes, I am.
And do you have any comment on that? Has that reduced the effectiveness of the hotel quarantine policy?
Well, as I say, there are the quarantine requirements and the referrals that we would make to FAC if we find that people are offside with respect to the quality of their quarantine plans or some other issue. I think the perimeter control regime is well established, and I think the infection rates demonstrate that.
Okay, well, let me explore that a bit. Media reports have revealed that mandatory hotel quarantine rules are not being enforced at 2 of the 4 Canadian airports currently permitted to receive international flights. That's in Montreal and in Calgary. Can you confirm if hotel quarantine rules are being enforced at these airports in those provinces?
Well, I think I would pass that question on to my colleague Ian Stewart at FAC because they're responsible for the enforcement of the hotel requirement.
Thank you, John. Mr. Chair and honorable member, I'd like to just add a couple things if I could. The public policy rationale of the government approved accommodations, the hotels, is that somebody comes off an international flight and then we don't know if they're infected and infectious or not. And so they do the test, they're tested immediately if they come off the plane. And then they go to the hotel to wait for the result because a lot of people coming in internationally, of course, are boarding a domestic flight. And what we didn't want was infected people, perhaps carrying the Indian variant or something like that, getting on a plane from Toronto to Winnipeg and infecting a bunch of people on the plane. That was the public policy rationale for that. At the land border, you don't get the same kind of profile. People are usually arriving in a conveyance and continuing on. So that would be one thing I wanted to mention. The other thing to mention is that the infection rate of people arriving by air is about 1.7%. So about 6,185 people out of about 369,000 people.
The question, Mr. Stewart, was on enforcement at those 2 airports.
I do understand, sir. I'm sorry. I just wanted to provide the background.
I'd like an answer to.
I'd just like to provide the background that at land, it's 0.3%. The threat at the land border is substantially smaller. We do, in fact, enforce at all 4 international airport points of entry. In 2 provinces, people destined for 2 provinces where we don't have Contraventions Act, we rely on litigation as opposed to tickets. And I think that's created the perception you're referring to.
Has there been any litigation initiated?
Thank you, Mr. Davies. Go ahead and witness my answer, please.
Yes, of course there is. Yes.
Can you quantify that for us?
In the case of Saskatchewan, I believe, for instance, we have 15 court cases in process at this juncture.
Thank you, Mr. Davies. We'll go now to, we start our second round of questions now with Monsieur D'Entremont. Please go ahead, 5 minutes.
Thank you, Mr. Chair. Earlier, I think Mr. Stewart talked about 600 doses are coming in of AstraZeneca. Could you tell us which program that was from, whether that's from the COVAX program or whether that's from the bilateral contract that we're expecting?
the 655,000 doses that are currently being distributed were Canada accessing our payment under COVAX.
Okay. There is a bilateral contract with the manufacturer, so we're going to be expecting some doses from them as well. When will those be coming?
You're absolutely right. We have a procurement agreement with AstraZeneca for US production, and the first shipment's anticipated by the end of June, and then another 6.5 million in Q3.
Okay, thank you. I'm going to ask Dr. Tunis a question on, we have a number of issues around AstraZeneca. A lot of provinces have made a decision not to actually offer it to their populations. Will NACI be coming up with some advice on what to do with those folks that might not want to have AstraZeneca as their second dose?
Yes, thank you for the question, Mr. Chair. That is on the forward work plan for NACI. So the committee is currently reviewing evidence on interchangeability across vaccine platforms. And as Dr. Tam mentioned, we expect some of that evidence to become available later in the month or into early June. There's already been some publication or some news released, at least from a Spanish study looking at the same. So the committee is reviewing the scientific evidence on this topic in order to provide that advice on interchangeability. So the Public Health Agency of Canada does intend to ask NACI for their advice about options for individuals who have received AstraZeneca as a first dose and whether interchangeability might be an option. Thank you.
I mean, we know some people will be having their second doses pretty soon, especially the ones that got it earlier. So March, I think at the beginning of March when people started receiving AstraZeneca. Are we going to be a little crunched on time if we're waiting for another month or two?
So when we've looked at the national numbers, it's around the first week of June that individuals would start being available for their second dose, according to a 12-week or a 3-month interval for AstraZeneca vaccine. And so I'll also note that NACI has advised us that up to 16 weeks could be considered for an interval. And in fact, with the AstraZeneca vaccine in the clinical trials, an interval of 12 weeks or greater than 12 weeks actually was the most efficacious. So there are also options for extended interval beyond that first week of June as well. Thank you.
Okay, thank you. I don't know if this is for Health Canada or Public Health. Is there any legal concerns around giving Canadians a different brand from what they actually consented to originally?
Mr. Chair and honorable member, we do, of course, take into consideration consent. It's an important part of the vaccination process. The NACI study will create the guidance regarding the mixing of the two doses. I'm not aware of any legal issues that would arise in that nature. I would turn it to you, Teresa, based on your experience, if you have any comment or advice in that regard.
Mr. Chair, I have nothing further to add. I think the guidance will be based on the evidence that we have at the time, which is up and coming, and provinces will look at that evidence as they roll out the vaccine program, and absolutely informed consent is part of the process.
With vaccine hesitancy already a concern, when people were expecting both doses to be the same brand, how will government messaging ensure Canadians have confidence in the different vaccine regimen?
Was there a particular person? Oh, sorry, go ahead, Teresa.
Okay. So, Mr. Chair, look, vaccine confidence is extremely important. I think Canadians should know that between the regulator, the National Advisory Committee on Immunization, and the provinces structuring the vaccine programs, that thorough scientific data review as well as expert advice has been taken into account, so that they should feel confident that we have a effective, safe vaccines being provided, and that is very important for sure. And that when the advice comes out for the option of receiving the same dose for the second dose or a mixed dose schedule, they should know that that's come from a thorough review.
Okay, and a final quick question to Mr. Stewart. When you were brought up on the information for Major General Fortin, did they ask you not to mention it to Major General Fortin, or did you have a discussion with him from that March date to the date that you actually, the 13th?
I received no instruction about who to talk to regarding that information, to be honest.
Okay, thank you.
Thank you, Mr. D'Entremont. We'll go now to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 5 minutes.
Thank you, Mr. Chair, and thanks to all the witnesses for joining us today. This is quite a panel, and I appreciate you taking time off of your schedules to answer some questions today. I'd like to start with my questions with Dr. Tam. We continuously said that as we learn more about this virus, our approach evolves. And as we vaccinate more and more people from different priority groups and locations, I think it's fair to say that our knowledge about these vaccines evolves too. Now, I've heard of a few cases abroad where the antibodies were found in babies whose mothers received the vaccination while they were pregnant. I think this is certainly something to give us some hope. And I'm wondering if either nationally, internationally, you have seen any of these cases, and are there any studies about these situations? And if so, can you tell us about them?
Mr. Chair and Honourable Member, thank you for the question. And as you indicated, we're studying the science as we go along. And I think based on other vaccines, it wouldn't be surprising that some antibodies could, for example, be passed on from the mother to the baby, either through the womb or indeed through breast milk. So these are being studied. Yes, I have heard of some of these accounts, but that evidence is being reviewed. And we actually have research studies on vaccination for women who are during pregnancy as well, persons who are pregnant. And we will look forward to some of that data. It is also important to emphasize that women or persons who are pregnant have an increased risk of COVID-19. So, and the advice at this point in time is to offer persons who are pregnant the vaccine because of this increased risk. And it may provide some benefit to the baby, but that remains, I think, to be studied.
Thank you. Still on the topic of priority groups, our approach across Canada was to identify specific groups and target them for early vaccination. Could you please share with the committee how impactful this decision might have been?
Mr. Chair, that decision has been very impactful because COVID-19, of course, has a disproportionate impact on certain populations, including our most senior age groups, as well as those in congregate living settings, such as long-term care. And then, of course, those at high risk of exposure to the virus, such as healthcare workers. I'll just point out that in this third resurgence, the number of deaths, and every death is really, we should take note of, but the numbers are much smaller during this third wave, whereas we would have expected that to be much higher as the protection of the very effective vaccines. Long-term care facility cases and outbreaks have dramatically decreased. And that was the first thing that we noticed about the vaccine program. And then the rates in the over 80 years and over plummeted really at a very fast rate. So that was another really good sign. And vaccine effectiveness studies being carried out in Quebec and British Columbia indicate the effectiveness of that, even the first dose of vaccine. Healthcare worker cases have also dropped as a result of them being vaccinated as a priority group. So I do think that those prioritization has had an impact. First Nations communities, they were prioritized, and the territories, and have had a really high vaccine uptake. And I do think that the vaccine has played a very key role in protecting those populations.
Thank you. Now, throughout this entire study, and even through our previous study, we've heard from numerous witnesses about the importance of sharing health data across Canada. And while we've mostly heard about this in the context of COVID-19, I think it's applicable to other health-related contexts. Do you see a benefit in such a system? And if so, would it impact the efforts to prevent and to manage diseases across the country? Dr. Tam.
Mr. Chair, that is a very important question, and I think public health policy should be driven by data. And we have had data presented, and it has to come from the local level up to the national level. So I do think we've seen data improve over time. This is the first pandemic where we're having case-by-case data reported nationally. Through the Pan-Canadian Health Data Strategy, we've now, and the safe restart agreements and the actual resources being provided to the provinces and territories, we have seen improvements in the data being gathered, including on race, indigeneity, and occupation. So that has improved, and that kind of improvement must be taken forward as we look to keep going in strengthening that data system.
Thank you, Dr. Tam.
Thank you, Mr. Van Bynen. We go now, I believe it's to Mr. Barlow, please, 5 minutes.
Thank you very much, Mr. Chair. Sorry, I just have the video off. I'm saving my rural internet here. Just to go along with what Dr. Tam was saying about the decisions on public health have to be based on data. Dr. Tam, what data shows that requiring a fully vaccinated international traveler to stay at a quarantine hotel is more effective than stopping the spread of COVID than quarantining at home? Is there some data that shows that that hotel quarantining is more effective than quarantining at home?
Well, we're very actively examining the policies related to vaccinated travelers or fully vaccinated travelers.
But right now, Dr. Tam, there's no data that right now you've made a decision on the hotel quarantines without the data that shows that it is more effective than quarantining at home.
That policy will be evolving because there hasn't actually been that many fully vaccinated travelers, and Canada is still in a very difficult situation with a third wave, and our domestic vaccination rate is still catching up, and it's accelerating. But I think part of the decision making related to vaccinated travelers has to take into account the global as well as domestic epidemiologic situation. And we're still learning about the reduction in transmission.
No, I appreciate that. It was a pretty yes or no question, but we've had the quarantine hotels for many months. Is there any data that shows for any traveler that the spread of the vaccine is controlled any better in a hotel quarantine situation compared to quarantining at home?
So the GAAs or these accommodations are there so that we can wait for the PCR results. That's the primary, rationale for doing that. So, and that's been effective in that PCR positive individuals are then referred to quarantine facilities. So from that perspective, it doesn't matter whether you're vaccinated or not. If you're positive and your PCR is positive, you will be quarantined and to ensure safety for the individual and for the population.
Right, but so I'm getting from that, Dr. Tam, that there's no data that shows that the spread of the virus is any better, or controlling the spread of the virus is any better at a hotel quarantine or from quarantining at home. But I want to change to the vaccinations on travel and to try and clarify some misinformation or miscommunication that's happened over the last week, either to CBSA or to Ian Stewart. Are Canadians exempt from quarantine if they cross the land border to the United States with appropriate documentation for the purpose of vaccination and immediately return?
Well, so you're referring to an exemption that was created for people who have like a specialized cancer and want to go to the Mayo Clinic. And to do that, they get a letter from their physician saying they need to go and get that medical treatment. And on that basis, they can return because they're ill and they're under treatment, free of quarantine. And I believe some people have used that and secured that to go and get a vaccine. We have 23 million vaccines in the country right now. And so I guess I would wonder why a physician would write a letter in that regard. It was intended for specialized medical treatment. So we've tried to clarify that, Mr. Chair and Honorable Member.
Right. And I don't know if that clarification has worked very well from 24 hours difference in between two messages, but the question is not even for special circumstances, Mr. Stewart. If a Canadian has a doctor's letter to go across the border to the United States, get vaccinated, and return, are they exempt from quarantine?
Well, I guess I would add to that, for the United States government, they do not view that as a reason to enter their country. From our perspective, I would ask the physician involved, does it actually require they leave the country to get what they can get at a drugstore?
Mr. Stewart, the question is yes or no. Are they exempt from the quarantine? Not whether or not the doctor is giving them a note and should he give them a note. The question is, if they have that note, regardless of how it came about, if they go down to the United States, get vaccinated and return, are they exempt from quarantine, yes or no?
I believe that the border services officers will not be accepting that. I'll let my colleague, John Ozowski, speak to the border services officers' exercise of discretion, but it would be inconsistent with what our expectations are.
So thank you for the question, Chair. So my understanding is that that to Ian's point, first of all, you would likely not be allowed into the United States to receive a vaccine. For people that do have a medical treatment, we will not require them to do the testing and quarantine requirements, and we will not be adjudicating that medical note. So if they don't have a note, then they're for sure going to be subject to all of the testing and quarantine requirements.
So if no, then why was that, maybe to Mr. Stewart, and again, I would say a doctor's note for a vaccine is a medical reason, regardless if it's cancer or something else. I think to get a vaccine is a good medical reason to get a note. But why was the advice provided differently last week and then reversed 24 hours later? What was the reason for providing the advice that yes, you would be exempt from quarantine, and then that reversed 24 hours later?
Well, the reality is the world around us is changing. There are 23 million vaccines in the country at present. And if you need to get a vaccine, there are plenty of pathways to do so, whether through the province or a drugstore or whatever.
So you're basing
Thank you, Mr. Barlow. Thank you.
Thank you, Mr. Chair.
We'll go now to Mr. Kellaway. Mr. Kellaway, please go ahead. 5 minutes.
Thank you, Mr. Chair, and hello to my colleagues, and thanks again for the witnesses coming here today. My first two questions will be directed to Dr. Stewart, and if I can, I'm going to ask a third question to Dr. Tam. And then my questions are going to change a little bit. I was going to ask some questions around vaccines, but from what I'm hearing today and what I'm learning on a daily basis, we're trending in the right direction with respect to doses. I mean, we're looking at 19.6 million doses of COVID-19 vaccines being administered so far in the country. And if I'm not mistaken, that's a little bit over 55% of eligible adults have received at least one dose. So that's really encouraging. But I'm going to pivot to rapid tests, actually. So my first question, Dr. Stewart, as you know, as everyone knows, I'm from Nova Scotia, and our province has done a really good job at managing the virus. But the third wave, I have to tell you, has been challenging here. And this week, the Nova Scotia Health Authority said that its province's asymptomatic rapid testing sites have been key in identifying, I think it is at least 10% of all confirmed cases. So my question to you, are there any lessons to be learned from Nova Scotia's experience with rapid tests?
Mr. Stewart, you're muted.
Sorry about that. I'm not a doctor. Thank you, Mr. Chair and honorable member.
Okay.
And I'm also from Nova Scotia as well. What I would add, though, is it's actually my colleague, Stephen Lucas, who speaks to the testing topic. So I'll just ask him and take that question. Thank you.
Thank you very much.
Okay, thank you, Mr. Chair. As I noted before, Nova Scotia has really been a leader in the use of rapid tests as part of their broader program. They have, prior to the resurgence that they've been experiencing, used it to effect in downtown Halifax, as I'd noted. Now they have a broader utilization of rapid tests for screening purposes, which allows for quick determination of potential or presumptive positives and then follow-up confirmatory tests. That can lead to broader screening in a workplace if, for example, cases are detected, or in other settings, and effective utilization of the PCR tests. And I think that has allowed them to really get a broad handle on the number of cases and effective tracing and isolation of cases and contacts, allowing for the steps they've taken, coupled with other public health measures, to control the spread and bend the curve down of the resurgence they experienced.
Thank you, Dr. Lewis. And I'll stay with you, Dr. Lewis, or Lucas rather, and not Mr. Stewart. Do you think that the federal government should take further action to promote increased usage of rapid tests? And if so, how?
Well, thank you, Mr. Chair. The government is working on a number of pathways, as I'd responded to a previous member's question. The government has distributed a significant number of rapid tests to provinces and territories. That started in the fall, and worked to provide guidance and support on their use. We have been providing rapid tests directly to employers working in critical sectors where there's a risk of infection in the workplace, working as well with pharmacies to distribute rapid tests to small and medium-sized enterprises, supporting the Canadian Chamber of Commerce for a program where they partner with provinces to be able to distribute rapid tests to small businesses, and as well supporting the Canadian Red Cross, who are working with not-for-profit organizations and community organizations or settings such as homeless shelters to be able to use rapid tests in those environments. So we see this multi-pronged effort as really helping to be able to identify those cases and follow up with action, as I noted in the case of Nova Scotia.
Thank you, Dr. Lucas. Dr. Tam, as you know, last summer, those of us in the Atlantic region were able to travel within the famous Atlantic bubble. Now that there are more and more Canadians getting vaccinated, is there anything stopping the provinces for implementing their own interprovincial measures similar to the Atlantic provinces and the territories?
Mr. Chair, thank you for the question, and that is a provincial matter. But I do know that the Atlantic provinces, of course, having ongoing discussions amongst themselves, but also at the Special Advisory Committee where all provinces and territories participate. Those are the types of discussions that are taking place, but it is, of course, up to the provinces. They are looking at their policies for interprovincial travel.
Thank you, Mr. Chair. That's all for me.
Thank you, Mr. Kellaway. We'll go now. Nous allons maintenant, Monsieur.
We'll go now to Mr. Thériault. Mr. Thériault, go ahead, please. 2.5 minutes. Thank you very much, Mr. Chair. My question will be for Mr. Ossowski. In the spring of the first wave, people wouldn't have thought that we'd be talking of vaccines today, perhaps. The government passed a special law to allow the suspension of patents, to allow vaccines to be produced, and now, poof, the provision has disappeared, and we've had to depend on others abroad for vaccine procurement. The question is simple. Why was that not continued? Would there have been pressure in your negotiations with the pharmaceutical companies for that to not be continued? Why not continue that provision?
Thank you, Mr. Chair. I think probably my colleague Bill Matthews is better placed, or Stephen Lucas, to answer this question.
Mr. Chair, I can address that. There was a provision in an Emergency Provisions Act in March 2020 pertaining to compulsory licensing. At that time, it was unclear what the development path would be for therapies and vaccines pertaining to COVID. Since that time, we saw the rapid development of vaccines and their authorization here in Canada and around the world, as well as the establishment of global facilities such as COVAX to enable distribution of vaccines around the world, and particularly in low and middle income countries.
Excuse me, that's not my question. My question is, when a law is made and there would be product production under licensing in Canada. Once vaccines emerge, that option was taken away. So was there pressure, were there representations from pharmaceutical companies to take that away so that that wouldn't be used? Or was there that type of exchange? That's my question.
Mr. Chair, I'll respond in saying that the assessment was that that provision did not need to be renewed. As I'd indicated, we were working with vaccine developers for their authorization. The government has announced investments in and partnerships with a number of Canadian companies, as well as, for example, Novavax, working with the NRC for production of vaccine in Canada.
Merci, Mr. Theriault.
Thank you, Mr. Theriault.
Go now to Mr. Davies. 2.5 minutes, please.
Mr. Stewart, I was asking about lack of enforcement of hotel quarantine rules in Alberta and Quebec, and you responded that we've initiated litigation in Saskatchewan. Has any litigation been initiated in Alberta and Quebec by the federal government?
With respect to Alberta, I'll have to, Honourable Member and Mr. Chair, get back to you with the statistics. Off the top of my head, I don't remember the litigation statistic for Alberta. For Montreal, we in fact ticket there, and we have a good relationship with the police of local jurisdiction, so we rely on tickets under the Contraventions Act.
Okay, well, it was my understanding that Quebec is not enforcing the hotel quarantine rules coming out of the Pierre Elliott Trudeau International Airport. Am I wrong on that, or is the media reports have that wrong?
Well, I just have in my table of the contraventions, tickets, and report incidents that have been issued, we have 192 tickets that have been issued. And for Quebec, 190 of them have been for a breach of quarantine. So I think the fact pattern is that there is ticketing going on with respect to the jurisdictions in Quebec.
Okay, and I want to just make sure I understand this. Maybe I have it wrong, but we have a passenger flying to Canada from Brazil, and they're going to land, say, in Calgary. They have to hotel quarantine. But if that passenger instead changes their ticket to fly to Montana and then drives across, the hotel quarantine rule does not apply to them. And if I understand you correctly, you think that that jibes with our policy design. Can you explain that to me again, why the hotel quarantine rule applies to one but not the other?
Yes, I can. So the person flying in from Brazil would have to land in Montana. They'd have to stop, and they actually have to get a PCR test in the United States before they even come to the border. And they have to show up at the border with a negative PCR test. And then they have to do a day 1 test. They have to go into quarantine for 14 days, and they have to do a day 8 test. So the full testing and quarantine regime pertains. But because they're not going to do a connector flight through an international flight into one of our 4 airports, the GAA hotel is less, there's less of a public health benefit for it.
But isn't the whole point of the hotel quarantining to protect Canadians, to have an extra buffer so that that passenger stays in a hotel after they land here? Is that not the point of quarantining? Obviously, it can't protect the people on the airplane because they've already been on the airplane. The quarantine in the hotel happens after they've entered Canada. So am I missing something there?
It's the connector flight. If somebody flies in from Brazil, they land in Toronto, they get tested, they have to wait to get the result before we let them get on another public conveyance of Canadians. If they show up at the airport, therefore, they're at risk of exposing others because they're going to use other conveyances. So that's the GAA. That's why that's the benefit for international air flights. If they're going to fly into the US, they have to land. They have to get a brand new PCR test right there. It has to be negative before they can even enter the country.
Well, I thought.
Thank you, Mr. Davies.
Thank you.
We go now to Ms. Rempel-Garner, please. We're starting our 3rd round of questions. Ms. Rempel-Garner, please go ahead. 5 minutes.
Thank you, Chair. Dr. Lucas, 11 days ago, David Musich, the CEO of the Windsor Regional Hospital, applied through Health Canada's Special Access Program to have access vaccines from Detroit, which are currently going to waste, delivered to his hospital for use in Windsor. By what date do you expect your department to approve this request?
Mr. Chair, I don't have that information at hand in terms of that request. As has been noted, there are vaccines available in Canada and being distributed in across the country.
The name Dr. Lucas of your employee who's working on the file is Mary Morgan. You might want to get her on the phone after this. Do you have any idea about this request? Like, are you tracking it at all? It's a fairly significant one. It's made the media quite a bit in the last 24 hours.
I am aware, but Mr. Chair, I don't have the specific details on the follow-up as I had conveyed.
Would you commit to perhaps phoning Dr. Musage this afternoon to deal with this request? It's been 11 days.
I will follow up with the program, Mr. Chair, but what I would say, I mean, the special access program is designed for accessing medications that aren't authorized for use in the country. It's a unique program. The vaccines are...
So vaccines are going in the garbage today in Detroit, and they want to send them to Canada because they're about to be wasted. But this is a great segue to my next line of question. Dr. Stewart, you implied that there was enough vaccines in Canada right now, that there was 20 million vaccines and that there was plenty of pathways to get a vaccine for Canadians. What would you tell somebody who has signed up for an appointment in Ontario but is waiting for a month, who perhaps is a frontline worker? Do you think that's an adequate pathway to get a vaccine?
Mr. Chair and Honourable Member, just while we were talking, we were looking at Vaccine Hunter for Windsor, and there are vacancies available right now in the city of Windsor for those seeking vaccination. Of course, in any program where you're increasing the number of vaccines available in a jurisdiction, there's going to be a period.
That, however, I just don't accept the assertion that we have enough vaccines in Canada right now. We're on a nationwide, essentially, lockdown, waiting, and some people are being told 4 months between. NACI's approved a 4-month dosing. So I find it problematic that the head of PHAC thinks that we have adequate supply in Canada right now, and that we shouldn't be pursuing every option for Canadians to get vaccinated. I mean, Vaccine Hunter is not going to vaccinate every Canadian in second doses, and it's just frankly preposterous and arrogant to make that comment. I will continue. Do you believe, Mr. Stewart, that a physician telling a Canadian to, or writing a note to go get a vaccine in the US is not medically necessary, based on your comments that you made earlier?
Yes, thank you, Mr. Chair. Thank you, Honourable Member. What I said was there were 23 million vaccines in the country. I don't know, I said that that was sufficient. We ourselves like to pursue additional doses, and we work closely with PSBC and Minister Anand for opportunities to increase the overall supply. However, the rate of vaccination...
For the purposes of the OID,
would you please
this is my time. This is my time. For the purposes of the OIC...
Ms. Shumpel-Garner, please let the witness answer. I will allow time.
Point of order, Chair. I know, I understand that people don't like it when I am direct, but this is my time, and these are questions Canadians need answered, and I won't be overtalked or told what I can and can't do. So I will direct my time accordingly.
We are expected to give due courtesy to the witnesses.
No, being polite, in your opinion, is a tool of the patriarchy, and I will continue. Thank you.
It is a prerogative. It is a prerogative of the chair to allocate
Mr.
time.
Stewart.
I will normally delegate that to the members, but I would like to give the witness a chance to respond.
Well, then I will ask my question again. Mr. Stewart, do you believe that per the OIC, traveling across the borders, the government's direction that traveling across the border with a doctor's note to get a vaccine, is that medically necessary?
Mr. Chair and Honourable Member, the U.S. government has indicated they don't view that as a reason to enter the United States.
I asked what our government was doing.
And I would go on to continue to answer your question, ma'am. From our perspective, it entails risk. Somebody has to go across the border. They expose a potential risk for exposure in that country and then coming back. So it would be normal that they would do all of the testing and quarantine related to entering the United States.
Thank you. To Dr. Stewart or Dr. Lucas, either or, on what date will fully vaccinated travelers be exempt from quarantine upon entering Canada?
If I may, Mr. Chair and Honourable Member, that's a question that, in fact, Dr. Tam would probably be more appropriate to speak to.
There's both a public health set of considerations and operational. One is that we want to see that Canada's epidemic under control and that our population has had the chance to get fully vaccinated as well.
Earlier, on that point, Dr. Tam, earlier in your testimony, you noted that the fact that there weren't enough Canadians fully vaccinated, that was part of the reason why we weren't looking at allowing fully vaccinated travelers to exempt from quarantine hotel. Do you have a date or a benchmark by which that might be lifted?
Well, I think we have to look at the data as we go, but I think that we are on track to have 2 doses provided to Canadians by the 4th. So
and so that's when fully vaccinated travelers would be exempt from quarantine, is the fall.
There may be other provisions to change what we would do with vaccinated travelers.
When would those be?
Thank
when
you,
would
Ms.
that be
Rampel-Garner.
happening?
Thank you,
Mr. Chair. I have a point of order, Mr. Chair, if I may.
Mr. Davies on a point of order, please. Go ahead.
Thank you. Mr. Chair, I was advised about 5 minutes ago, I didn't want to interrupt my honorable colleague in her questioning, that this entire meeting has not been online up until I think maybe a minute or 2 ago. Is that the case? Journalists have not been able to follow this right up until about a minute ago.
I'm not aware of that.
Let me
Clerk.
Let me check with the technician people.
I'm advised that it's working now, but it hasn't been. Journalists have been contacting our media people saying that the proceedings have not been online right up until a minute or 2 ago.
Thank you for bringing that to our attention. I'll ask the clerk once he finds out about what's going on there. I do understand where we're going now. Ms. Rampel-Garner, I think you have, well, your time is officially up, but let's give you another 30 seconds if you wish to finish up.
Thank you. So the fall is when fully vaccinated travelers would not have to go through a quarantine hotel to enter Canada, Dr. Tam.
I think we're evaluating those policies right now.
Do you think that not having some language on that by this point is sort of harming Canadians because you're not providing them with some hope?
I do think that it's important to provide some hope, and I think that the international arena is discussing this right now, and I do think that vaccines will play a role in facilitating travel.
Do you have any line of sight on when that might come out?
Like Thank you, Ms. Rampel-Garner. Thank you, Ms. Rampel-Garner. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead. 5 minutes.
Thank you, Mr. Chair. And I think conducting meetings and asking questions and actually allowing the answers isn't a sign of the patriarchy. It's actually doing our jobs as MPs to get the testimony for the witnesses we asked to be here. So in that vein, I just want to talk about, it's interesting, the Conservatives talk about we were never going to have vaccines until 2030. Then today they're saying we have to get more vaccines or allow Canadians to take additional risks to go to the US, even though there are vaccines available in Canada right now. And actually, I believe it was yesterday that Canada has actually surpassed the US in first doses. How appropriate would it be that if we're actually administering more doses, first doses, to Canadians than the US, to actually take supply away from another country when we have adequate supply here? So I guess I find that a little bit odd. But I want to speak to the first dose strategy. I have a number of questions, but the first dose strategy, this was also criticized by Conservatives, which again is very confusing because you can't get a second dose until you have a first dose. So it makes a lot of sense to administer first doses. And again, we have surpassed the US in this. So I guess to Dr. Tam, or if there are others who'd like to jump in, but on the rationale behind first doses, the real world data has looked very promising in terms of protection, although not 100% protected after a first dose. but real world data on first doses, as well as something I know the minister likes to talk a lot about, that a community with less COVID is safer for everyone. Therefore, if you have a lower risk, even with a first dose, that in fact makes your community safer because that spread is down. Could you maybe speak to that piece of it and why it's important for Canadians to continue to get that first dose and why it's so important that our momentum for vaccines and these doses is increasing and continuing?
Mr. Chair, maybe I'll start with the answer to that question. So I think the first dose fast strategy was taken up as a result of the National Advisory Committee on Immunization reviewing existing information on the COVID-19 vaccines, but also a wealth of knowledge about vaccinology, immunology, and how vaccines work, decades of experience in that. And together with mathematical modeling and other considerations, meant that there was a consensus amongst chief medical officers of health and provinces and territories to do this strategy. And I think it has paid off and has contributed to increasing population protection. More and more data is coming out, including that from the United Kingdom, which shows that that first dose offers significant protection, and particularly for serious outcomes, and that the duration of that protection does last. And we also have Canadian data from Quebec and British Columbia, which I think will provide the world's first glimpse into just how good that first dose is, even beyond the sort of 12-week mark. So it's been very, very encouraging. And so if you can imagine, if you're doing mathematical modeling, covering twice as much of the population with a effective first dose provides significant benefits. But that doesn't mean you can forget the second dose. You have to come back fast with that second dose. And on that, I want to sort of just clarify that the National Advisory Committee on Immunization said up to 16 weeks. And I think as the supplies improve, we will see that interval potentially being compressed more. I believe British Columbia has just come out yesterday with a 13-week interval now, given their supply management. So you will see, I think, that interval being more compressed as we go along as well. But just to rest assured to Canadians, that first dose do matter, and they have worked and have prevented a lot of serious outcomes in Canada already.
Thank you. And the UK strategy of this first dose, you know, we were constant. Oh, I had a question from Dr. Tunis, but I guess I'll have to come back.
Just finish it up quickly.
Okay, Dr. Tunis, I don't see on my screen here, but there you go. You spoke earlier in the testimony about AZ, and you were talking about the dosing interval. For the average Canadian and putting it in regular speak, can you talk about, you were talking about that, that effectiveness being extended, or some studies showing that. Can you maybe put that, explain that without some of the medical terms, and actually explain what that means for the average Canadian who got the AstraZeneca dose?
Thank you for the question. So I can attempt that. So NACI has advised us that based on what we know about the immune system, intervals that are longer can provide the immune system more time to generate a robust immune response. So we've seen that in some of the clinical trials, like for AstraZeneca, a longer interval resulted in more protection and a better immune response. There have also been now some studies being published showing similarly for the Pfizer vaccine, and that a longer interval can provide a stronger immune response. So these are all things that the committee continues to weigh out as they look at the interval strategy. And as Dr. Tam said, jurisdictions are now looking at whether they can revise their strategies as supply is shifting. And NACI has always said up to 16 weeks could be used based on their deep understanding of the immune system and immune responses, and what we've seen historically from other vaccines, where more time can allow the immune system more time to generate a better response. Thank you.
Thank you, Ms. O'Connell. That went way over what I expected, so I will give Mr. McGuire a little extra time here. I just want to update the committee in response to Mr. Davies' point of order. My understanding is that there was a brief interval at the beginning of the meeting, about 3 to 5 minutes, where WebView and ParlView were not operating, but it has been operating since. So that's my information. So Mr. McGuire, please go ahead. I'll give you 5 minutes plus. Thanks,
Mr. Chair. I just wanted to direct the question to Mr. Stewart. And during the emergency debate and then your last appearance before the committee, I raised the issue of rural Canadians not being able to send back their 2 PCR tests due to the Purilator's lack of presence in small communities. And just this morning, our committee was notified that over 17% of the tests have not arrived on time. So just maybe yes or no, since I've raised this issue, have you identified any other companies that are going to fill this gap?
Mr. Chair and honorable member, thank you for the question. Well, we've done a number of things actually to try and address the backlog that you're talking about on timeliness. Number one, we tried to reduce the impact of it by moving the test is now a day 8 test. So if there is a delay, it's less likely to impact travelers. Number two, we have looked for alternate service providers or enhancement of service providers.
Is this still a Switch Health decision, or are there other companies helping Purelator do this now?
Well,
that was my question.
Yeah, so Switch Health remains the service provider for a lot of areas, and they have been working with Purelator, but they have also worked 2 ways. One, they've tried to encourage the level of service, increase the level of service that Purelator is providing, like drop boxes. And
yeah,
2,
but this
they have
months ago, Mr. Stewart. Sorry, this was months ago. We raised this, and so I know that the PCR tests are not being sent in on time, and it's clear the system's still not working. So, are you telling the committee and the Health Committee here today that did absolutely nothing, that Health Canada has done absolutely nothing with the information provided to them months ago in regards to getting other people to help Purelator get these tests on time?
Mr. Chair and honorable member, actually what I was trying to say was that they have started working with alternate service providers as well. For instance, I said they're trying to increase the service from Purelator, but they've also recruited other service providers as well, such as Uber, in fact, 3 other service providers in this space. So we are on it, and we are trying to improve the performance to ensure Canadians get their tests.
So can you give us any kind of a specific date, because they're still lapsing, when this issue will be fixed, so rural Canadians particularly don't have to wait days for their test to be picked up, and so they can stop leaving them outside in the elements while they're waiting to be picked up?
Part of the service delivery package is, honorable member, that we have drop boxes. As the population gets more sparse, obviously it's more difficult to do door-to-door delivery, so the drop boxes will continue. When you refer to them being left outside, perhaps you have a specific example that we could investigate.
Yeah, I raised it a couple of months ago. Can you please table with the committee the contract that the Government of Canada signed with Switch Health by next Wednesday?
Mr. Chair and honorable member, we do have the Deputy Minister of Procurement and Public Services Canada with us, and he might be better placed than I am to speak to your request, sir.
Thank you, Mr. Chair. A couple of things to point out. Number one, we are pressuring Switch to improve service because it is uneven. It's working well in some areas and less in others. And Ian Stewart just mentioned a few improvements, but we continue to work with Switch to get better service because we know it's uneven.
Can you table the contract by next Wednesday?
And part 2, I will look at the contract and see what can be tabled. I can't commit to next Wednesday only because we would have to go through and agree on redactions with the company, and that typically involves review with legal, etc. So it often takes more than a few days. Well, I can take back the request.
We already can't. We already haven't been provided with the contracts from the vaccine contracts, and now it looks like we're not getting even a contract from somebody like a courier, basically Switch Health, the company that's trying to pick these things up, and mainly it is from rural areas that are the problem here. And so, why are we trying? Why is that so important? Why are we hiding a Switch Health contract? I mean, it's a transportation issue.
I think, Mr. Chair, it's more a matter of, as the department responsible for procurement, we take the contracts very seriously, and we don't just release contract information without a discussion with the supplier. And industry watches how we handle ourselves in these circumstances, because there are certain types of information that are commercial confidence.
So I get what you're saying is that we can't see the contract. Just a quick for Dr. Tam. This morning we were informed that close to 5,000 specimens were unable to be tested. If the PCR test is left outside over 6 hours in either the heat or the cold while waiting to get picked up by Purelator, will that impact the veracity of these test results?
Perhaps, Mr. Chair and Honourable Member, maybe perhaps I could speak to that. We have not been having.
I was asking Dr. Tam, but.
Oh, I'm sorry. Okay.
Yeah, sorry, Mr. Stewart. Yeah. Yes, Dr. Tam.
Hello. So, Mr. Chair, I think the specimens are likely to still be reasonable to test. That's this is a PCR would detect the viral genetic material, and it shouldn't impact the quality of the test.
So how many days can a PCR test wait before being sent to the lab for test results, before they would be impacted? If someone, say, took a test today, but doesn't get it to the lab for 8 days, would that impact the veracity of those test results?
I can find you the more technical answer, but when it's just genetic material, you can detect it. It's like DNA being left around in an environment or in different places in different materials. We should be able to detect that, even if it was left.
That's how long some of these have been out. So I'm just raising that issue. Mr. Stewart, when I originally mentioned the concerns with Switch Health, it didn't seem very surprised, which indicates that the government has known about these issues for some time. So since the beginning of their contract, what specific changes has the government asked Switch Health to make? You alluded to that earlier, but what specific changes has the government asked them to make to ensure that the tests are being picked up on time?
Thank you for the question, Mr. Chair and Honourable Member. We have been working with Switch Health to improve their delivery. The key thing is for the people who are waiting for their 8-day tests in particular, and I believe when you talk about rural delays, it's those 8-day tests when people are in quarantine. So one of the things we did first of all was provide more time. We made it an 8-day test, not a day 10 test, so it was less likely to impact the person waiting for the result. We've added, as I mentioned, more service providers gathering up samples in rural areas. As I mentioned, 3 new service providers, and then for other areas, Uber as well. We've worked with the company on their level of staffing.
There's no Uber in rural Canada, Mr. Chair, or Mr. Stewart. And so I just wanted to say that I've got complaints from constituents about that entire process of submitting the 2 PCR tests after receiving.
Thank you, Mr. McGuire. So we'll go now to Dr. Pawlowski. Dr. Pawlowski, please go ahead, 5 minutes.
Thank you. My riding extends from the Thunder Bay border, to the Manitoba border. So it includes all the Canadian-US border in that region. So a very large region, a largely very isolated region. And many families, businesses have close connections with families and businesses on the other side of the border. A lot of people have been severely affected by the border closure. Grandparents haven't been able to see their grandkids. People haven't been able to see their children. People haven't been able to see their spouses. Also, businesses, particularly in Northwestern Ontario, businesses that deal with tourism have been really devastated because they're almost totally dependent on the American market and American tourists. There is increasing evidence that, especially being fully vaccinated, it significantly decreases the risk of transmission. The CDC, I think, in the United States is recommending, and we've seen the beginning of a relaxation of social measures. It seems to me the EU has announced that they will allow fully vaccinated Americans into the EU. Given the severity of the effects of the border closure, I think it is reasonable for people to ask, when can we expect some sort of decision as to the border being opened? And I would suggest certainly the summer would seem to me a reasonable time, especially given the effects on the tourism industry, where a lot of businesses, if there's no American tourists this year, they're going to go bankrupt, and a lot of people will lose their livelihood. I know Ms. Rumpel Gardner asked this question, but I think it's a reasonable question. When can we expect to hear when fully vaccinated people, especially Americans, will be allowed into Canada? Maybe Dr. Tam?
Thank you for that question. I think it's an extremely reasonable one, and that we are working very hard at looking at the options going forwards. As I hope all members know, that the orders in council do get relooked at on a very frequent basis, and I expect that we will be incorporating some of these policies in the upcoming ones.
And by upcoming, we're looking at what sort of period of time?
I do think that Canada is probably on a good trajectory in terms of its epidemiology and our own vaccination coverage. And so I do think that between now and moving towards the fall, we would expect some shift in that policy. I think one of the other aspects to remember is, of course, we have to actually look at the proof of vaccination. So there's, as I said, some operational consideration and standards and that type of thing that needs to be worked out as well. We do also expect to continue, I think, to do some testing, even in vaccinated individuals, given the potential for variants that may have escaped vaccines, for example. And so we would be taking all of those factors into account.
Okay. Now, correct me if I'm wrong, but I think you are a pediatric infectious disease specialist. Ontario, the schools have been closed for, I don't know, what, six weeks, at least in Thunder Bay. We kind of started before the rest of Ontario. I think you'll agree there's pretty good evidence that kids missing prolonged amounts of school potentially suffer long-term learning consequences, and that's certainly a significant thing. We know, I think, that there haven't been a lot of cases of significant spread within the schools. However, there have been some. What are your recommendations, and what is PHAC's recommendations to the provinces regarding the timing and the importance of reopening schools?
Well, I think schools are very important to children, and it is a topic that all chief medical officers are seized with. This is, of course, in the jurisdiction of the provinces and depends on the epidemiology in the individual locations. So you might expect schools in Newfoundland to be open for in different periods to that, for example, in Ontario. So it is a very much a provincial jurisdiction, and a lot of it depends on the epidemiology of what's going on outside that school, not necessarily focusing on transmission in schools. I do think that now that vaccines are available, teachers getting vaccinated would also help that those safe returns in schools as well.
Thank you, Dr. Plosky. Nous allons maintenant, Monsieur.
We will now go to Mr. Tidio again. Mr. Tidio, go ahead, please. Thank you, Mr. Chair. 2.5 minutes. Dr. Tam. Currently, there are contradictory opinions regarding the administration of the second dose or not giving the second dose when a person had the virus. What is your opinion on that?
Et pourquoi?
And why?
I hope I understood the question correctly. So if someone's already had COVID-19, currently the National Advisory Committee on Immunizations recommendation is still to provide the full schedule of vaccines. But I believe that they will be reviewing that information on an ongoing basis, because as probably the public are interested in, it is likely that the original infection provides some level of immunity. We know vaccines provide better immunity in terms of antibody responses than the actual natural infection in a lot of the studies. So giving a vaccine after someone who had got infected is still the recommendation, but I look towards the committee to provide further information on the exact number of doses.
Do we have evidence currently or studies regarding how long it would be necessary to adapt a vaccine to a variant?
Par exemple.
For example, when we're faced with when we're using an mRNA vaccine.
Mr. Chair, thank you for that question. And with the, it depends on the technology for the vaccine, but for the mRNA vaccine, one of the benefits is that it can be easily adjusted and to different variants should there be a need. And just on that point, we know that the manufacturers of a whole suite of vaccine manufacturers are already looking at different vaccines that are more adapted to some of the variants that have been picked up globally. So that study is already, taking place. And we expect that to be quite fast.
Est-ce que les vaccins de
Would booster doses be adapted? And based on the deployment of vaccines now, could you tell us when we would need to look at booster doses?
I think that question is still being analyzed in terms of a response. But all to say is that right now, with the variants that are circulating globally, even if there's a reduced response to the vaccine, we do expect that the current vaccines will stimulate coverage for most of the variants that are circulating. And so the question of boosters, people have sort of come up with certain, I guess, opinions or perspectives, but I actually don't think we know the answer to that question, and we must monitor both the virus and the duration of the vaccine immunity, which is being done at the moment on an ongoing basis.
Thank you, Monsieur Theriault. We'll go now to Mr. Davies. Mr. Davies, go ahead, please. 2 minutes and a half.
Thank you. Dr. Tunis, is there currently any effectiveness data available demonstrating that protection from a single dose of an approved mRNA vaccine 4 months from vaccination?
So thank you for the question. Effectiveness has been monitored in the United Kingdom and also here in Canada. There are not currently published estimates looking at 16-week or 4-month effectiveness.
Thank
interval.
you. I guess this is to you, maybe, Mr. Stewart. In April, the US FDA stopped AstraZeneca from using the Emergent Biosolutions plant in Baltimore, and they halted production of the Janssen vaccine as it began an investigation into multiple areas of concern, including contamination and quality control issues. On April 25th, Health Canada claimed to have verified that the 1.5 million doses of AstraZeneca vaccine imported into Canada from that facility met the quality specifications. But the FDA's inspection report noted that, quote, there is no assurance that other batches have not been subject to cross-contamination. How was Health Canada able to verify the quality of those doses when the FDA is unable to provide assurances about vaccine batches produced at the plant were not subject to cross-contamination?
Mr. Chair, my colleague, Dr. Lucas, is actually responsible for that function.
Thank you. Dr. Lucas?
So, Mr. Chair, indeed, Health Canada had reviewed the lot and the information associated with the AstraZeneca doses that were imported from the United States. The timing of the production of those doses preceded the contamination. We are, by contrast, and that was as noted in the statement on April 25th. By contrast, the Janssen doses which arrived on April 28th are being held in quarantine as we work with Emergent, Janssen, and the US FDA to assess any potential risk of cross-contamination.
On that same day, Health Canada issued a statement regarding those contamination issues, and they claimed that, quote, Janssen vaccines anticipated to come into the country next week do not come from this facility. But 5 days later, on April 30th, Health Canada was forced to retract that statement after learning that a drug substance produced at the Emergent site was used in the manufacturing of the initial Janssen vaccines received on April 28th and intended for use in Canada. Why did Health Canada make an unverified statement of fact on the source of Canada's Janssen vaccines on April 25th?
Mr. Chair, at that time, we were working with information provided by the company, Janssen. Subsequent to that statement, we received information on the specific site of manufacture of the drug substance in the Janssen vaccines and issued our statement. And as a consequence of the concerns accruing from the US FDA report, placed the drugs under quarantine upon their arrival in Canada on the 28th of April.
Thanks. Mr. Osowski, we also know that hundreds of private flights from international destinations are landing at airports across Canada despite federal rules directing commercial and business air travelers to the 4 cities where quarantine hotel systems in place. Why are wealthy individuals being allowed to ignore Canada's COVID-19 restrictions and quarantine requirements for international air passengers if they arrive by private jet?
Thank you for the question, Chair. So happy to respond that we looked into that information and that reporting, and it's just factually incorrect. Half of the private flights that were cited in that were actually cargo flights that are bringing essential goods into Canada, including vaccines on some of those flights. So there's very, very few instances where some smaller aircraft are not going to the major airports. They're all being met by border service officers. They're all being given their vaccine kits. They're all going through the same protocols as everybody else. So unfortunately, it just was incomplete reporting.
But that's half the flights would be private jets. You said half are cargo. What about the other half? And they're still being exempt from hotel quarantine rules. Why is that?
Well, because to be more complete then, so there are a number of people that are trying to use taxi services, if you will, flying into the United States, and then they come back into Canada empty. Those flights, and crew are exempt. Flight crew are exempt from the quarantine requirements.
Do you have any idea how many individuals are using their private planes to land at these airports and avoiding the hotel quarantine rules?
I'd have to get that information for you, sir.
Could you please provide that to the committee? Thank you, Mr. I wonder if you could ask the witness to provide that information to the committee at his convenience.
I'll let the witness respond.
Yes, happy to do so.
Thank you.
Great, thank you. Thank you, Mr. Davies. I got distracted. You went way over there, Mr. Davies. So
I'm not the only one, it appears.
I know it's hard with 2.5 minutes slot. I know. Anyway, we're going now into our 4th round. We'll start with Mr. Barlow, I believe. Mr. Barlow, please go ahead.
Thanks, Mr. Chair. And I want to pick up on some of the questions that my colleague, Mr. Davies, had specifically to the Janssen vaccine. Dr. Lucas, when do you anticipate that we'll be receiving more doses of the Janssen vaccine?
Mr. Chair, I'm going to direct that question to Bill Matthews.
Thank you, Mr. Chair. So a couple of points, but the shorter answer is we can't confirm a shipment date just yet because those dates are very much caught up in that ongoing review that Dr. Lucas already mentioned of the Emergent facility. And until that facility is cleared from a regulatory perspective, we're on hold in terms of a schedule. But we can update the committee once we have further information.
Do you have any idea then when the FDA investigation will be complete and Health Canada will be able to make a decision on whether or not to release the doses of the Janssen vaccine received in late April?
Mr. Chair, I think I'll kick that back to Dr. Lucas.
So that I don't have a specific answer. The US FDA is continuing their work. We're working closely with them as well and doing our own assessment. We'll make a decision as soon as we have all the facts and the US FDA has concluded their work.
So with that in mind, Dr. Lucas, we've seen some of the provinces make some unilateral decisions on whether or not to provide the AstraZeneca vaccine to its constituents. Have we had any of the provinces signal to Health Canada that they do not intend to use the Janssen vaccine when it is available as well?
Mr. Chair, I'm not aware of any of those instances, but I'll turn to my colleague Ian Stewart, who has a direct contact with the provinces in terms of vaccine orders.
Thank you for the question. And actually, Mr. Chair, Teresa might also, Dr. Tam might have insight in that as well. I'll just state, just to answer your question, we've had no communications that I've received that they have no intention to take Janssen were it available. But Dr. Tam might have a more complete answer, so I'll turn to her.
So, Mr. Chair, at the last discussions amongst Chief Medical Officers of Health, I have not heard any specific discussions about not using the Janssen vaccine. We're waiting for.
Okay, that's good. I just want to know if there's been any concerns raised. I want to switch gears and thanks, Dr. Tam. I don't mean to cut you off. Just have a limited amount of time. Maybe to Mr. Stewart, on page 20 of the first interim report of the COVID Alert Apps Advisory Council, it states that the council acknowledges that the Government of Canada has consulted the Statistics Canada regarding any data of value that may be collected, that it may be collecting. What data is being referred to here, either Dr. Lucas or Mr. Stewart?
Thank you. Yes, off the top of my head, Mr. Chair, I don't know the citation you're referencing, but it may be that either Teresa or Stephen does. So I'll just open it up that way, if I may.
I'm not aware of the specific citation, but Mr. Chair, we could follow up with a specific answer in regard to the question.
Well, then to Dr. Lucas, we've been told from the beginning that the COVID Alert app wasn't really going to be used to collect any data on Canadians. It was just a matter of keeping track of close contacts and those things. But the report, and that's the first interim report on the Alert Apps Advisory Council, also says that the council wants to continue to be engaged in discussions on collection of data, particularly the viability of data collection given privacy considerations. So it's clear that this app is going to be used to be collecting data from Canadians. Do you know anything about this and what is being referred to here in terms of what data will be collected?
Mr. Chair, the app has very, very strong privacy protections. There's no information that's stored in the cloud. It's just strictly on the app. The app provides information on one-time key issuance. So, as that would be an example of data that can be collected. But any data has no personal identification, no ability to capture that. So I'll need to follow up on the specific in the report, but there is no data being extracted.
If you could be that, and Dr. Lucas, I don't mean to be the contrarian here, but in your first answer you said you don't know what they're referring to, and then now you're telling me that no data can be collected, but clearly in this report it is saying there are discussions that are happening on the collection of data. So maybe can you just table with the committee exactly what data may be referenced in this report? Also, how many Canadians could be affected and what the government is planning to do with any data that's being referenced in that Alert Apps Advisory Council report?
Sure. And just to clarify my response, your initial question mentioned Statistics Canada, and that's the point that I was not aware of a specific reference and would want to follow up to the page you noted. In regard to app data, it collects information such as the number of one-time keys issued, as an example, and that may have been what was referred to. We'll follow up with the committee.
Yeah, I appreciate it. If you can just table with the committee the answers to those questions, that would be certainly very welcome.
Thank you, Mr. Barlow.
Oh, thank you. Thanks, Mr. Chair.
We'll go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 5 minutes.
Thank you, Mr. Chair. My question is to Mr. Stewart or Dr. Tam. There's a concern among Canadians about the effectiveness of vaccine against the variants of concern based on real-world data. Can you tell us about the effectiveness of vaccine against variant of concern?
So, Mr. Chair, I will take a first attempt at answering that question. This is something that's being tracked globally in terms of vaccine impacts from various variants of concern and real life data that has to be collected. And so far, we know that the vast majority of the variants of concern are concerning because they have increased ability to spread. They spread quickly. In terms of the impact of vaccines, the current data suggests that for the B117 variant, and indeed for the latest variant of concern, the B1617 variant, originally reported from India, some of the subtypes are, we expect the vaccines to provide coverage for them. And for the other ones, there may be some reduced impact of the vaccine, but we still expect that the vaccine will work to a certain extent. So the most important thing is to get vaccinated. Of the variants, most spreading the most in Canada, we do expect the vaccines to have an impact on those variants.
Thank you. And Dr. Tom, you talked about how communication is the key. You mentioned some of the initiative you are working on it, increase vaccine uptake, such as connecting to Canadian through social media. And the federal government recently launched an advertising campaign called Ripple Effect on vaccinations and their benefit. What can you tell us about the message that campaign hopes to share with Canadians across the country?
Mr. Chair, I'll start, and maybe others who are more engaged on that front from a communication perspective can add. But that campaign is just one out of many approaches. But this is a much broader media campaign, and it demonstrates, I think, and to all Canadians that, of course, the vaccines protect individuals. But it also does have a ripple effect. It protects others in the community. And if we could all get vaccinated as fast as possible and do that, then we can get back to the things that we cherish the most with much less chances of impacting our healthcare system and other systems again. So I think the concept is that every time someone rolls up their sleeve, their impact permeates through their community, and as well as protecting them as individuals.
Thank you. We heard approximately 58% of adults have received at least one dose, and that number continuing to climb. My questions to Mr. Matthew: how does our vaccine procurement portfolio ensure that we are able to provide so many vaccines in such a short amount of time?
Thank you, Mr. Chair, for a couple of points, I guess. To start, the vaccine portfolio includes vaccines across 3 platforms. I think as members know, there are 4 authorized in Canada, but Moderna, Pfizer, Janssen, and AstraZeneca, but Pfizer and Moderna make up the vast majority of deliveries to date. The other point to make is there's still vaccine contracts that have yet to deliver. They're still in the works in terms of stepping through their clinical trials and then on to production. So it's the variety of the portfolio across numerous types of vaccines, but also numerous different suppliers that is the best mitigation against risk in terms of lack of delivery, because there will be bumps, and there have been. We've seen those bumps. So it's that variety that's important to protect or ensure the deliveries for Canadians. If the member's question is more around what's the benefit of having various different types of vaccines from mRNA versus viral vector versus protein, I'd have to turn to Public Health Agency or maybe Dr. Tam.
So let me see if I can understand the question properly. So having broad ranges of vaccine was very important at the beginning of our vaccine program and our strategies, because we actually had very little information about how these vaccines were going to perform. I think I think the really fortunate thing for Canada is that all of the authorized vaccines, and you've seen how incredible the mRNA vaccines have performed in clinical trials. So I think it is important to have diversity in portfolio, but we also are very fortunate that our foundational vaccine backbone, which is the mRNA vaccine, including the Pfizer vaccine, is performing so well as well.
Thank you, Ms. Sadu. We go now to Mr. D'Entremont. Mr. D'Entremont, go ahead, please, 5 minutes.
Thank you very much. I want to go back to sort of where I left off when we were really talking about the COVAX doses. How many doses of vaccine is Canada going to be receiving from COVAX between now and maybe July
1st? Bill, do you want to take that, or do you want me?
I can start maybe, and Ian can chime in. So I think the COVAX schedule, the most recent delivery was already referred to, which was AstraZeneca in the past week or so. COVAX schedules tend to emerge a little bit on short notice, so I don't have an update in terms of what the next delivery might be. So I can't really forecast what might be coming into July 1st in terms of detailed schedules, but Ian may have something to add on that front.
I would just add that we are expecting within 5 weeks that we would get a next shipment. But as Bill says, they don't tend to provide precise tight dates, but that's our expectation within 5 weeks.
Will we at some point be stopping COVAX shipments, or what is that date going to be when we're going to stop doing that?
The need for AstraZeneca in general, whether our own advanced procurement agreement or COVAX and so on, is driven by what the provinces decide to do on second doses. So I think the NACI report we were discussing earlier would be an influential factor here, member. Thank you.
Yeah, that was going to be my next question. Because of this, the issue of going of provinces shutting down their AstraZeneca, will that change our need for those?
I think there is a scenario in which the United Kingdom data supports NACI giving guidance that the messenger RNA vaccines are a suitable second dose. And then in that instance, you might see, yes, less demand for AstraZeneca. I think there will continue to be a demand for AstraZeneca by people who are looking for a second dose and want the same vaccine and so on. And then as Teresa, I think, mentioned earlier, the messenger RNA vaccines don't always, you can have an allergic reaction and so on. So you want to have a diversity of portfolio. So there'll be some demand, but much less if that happened that way.
Okay, sort of my next question, probably to Mr. Matthews. You know, since provinces will not be using AstraZeneca as a first dose, our requirement for that vaccine will go down. Are we changing the contract with them? Are we requesting less AstraZeneca? Are we thinking of canceling that contract?
Couple of points to make here, Mr. Chair. There is a contract with AstraZeneca for 20 million doses, and the first deliveries against that were through an exchange that I think members are aware of. As the future kind of unfolds and we get a better sense of what provinces might want in terms of additional AstraZeneca doses through the Public Health Agency, we'll talk with AstraZeneca about potential changes to that schedule. And I think what has also been discussed in various forums, Canada does have the right to donate doses that it does not need.
Just quickly, because I know I'm going to run out of time quickly here too. When it comes to, and this is probably PHAC, proof of vaccination for Canadians, I mean, we were hearing a lot about vaccine passports or whatever we want to call them. You know, when will people need a proof of vaccination for Canadians wishing to travel?
So earlier, some discussion came up, Mr. Chair and Honourable Member, about this topic. I think we're very seized with preparing for having a significant number of people who are fully vaccinated, and then how do we adjust and respond at the border? And then there's a longer term issue of the international arrangements to allow Canadians who are vaccinated to go to Greece or wherever, the internationalization of that issue. And that work is also underway. It's difficult, as Dr. Tam was saying, nail it down to a specific date, because there are a number of things that we have to watch, and that's including better understanding whether people arriving still can be carrying infection even though they've been vaccinated previously. That we still need to understand that better, I think, before we can go too far.
Okay, I mean, I'm aware of a number of people that are coming home from Florida, some snowbirds that actually have their 2 vaccinations. Is government finding a way to recognize the vaccinations happening in other countries?
We are working on how can we recognize exactly a scenario like you're talking about. If you think about people coming to the border who have, for instance, Pfizer, Moderna vaccines that we ourselves use here. So that is an active area of discussion.
And maybe a final question. I mean, on the broader of interprovincial travel, you know, is there a consideration of using, you know, checking this vaccination status in order to come into Nova Scotia or to go into other provinces?
So far, when it's come to measures regarding interprovincial travel, it's been the provinces who have been establishing those. And so far, the Government of Canada has not been active in that space.
Thank you.
Thank you, Mr. D'Entremont. We go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair. My question is for Mr. Stewart. With the recent increase in doses arriving in the country, provinces across Canada have been able to lower the eligibility criteria. In York Region alone, 52.7% of eligible residents have received at least 1 dose of the vaccine. I'm hoping that you can provide us with an update on how many people across Canada have been vaccinated to date in numbers and percentages, and particularly if you have the information with respect to younger age groups. Oh, I can't hear you.
Sorry, excuse me, Honourable Member and Mr. Chair. We do have that data. In fact, we do have it on our website, giving some of the coverage data of the nature you're talking about. And actually, we do keep an ongoing league table of by age stratification like you're discussing. And maybe the best way to respond to this is for me to generate the latest numbers and send them to the clerk for the members.
Thank you. Can you tell me why should we vaccinate adolescents before we vaccinate those at risk waiting for their 2nd dose? And does the added age group mean, what does the added age group mean for the rollout? And does that change the timeline?
Mr. Chair and Honourable Member, and this Teresa is actually probably better placed. I would just note that so far, in fact, we have not yet been getting to vaccinating a lot of youth and children and so on, but I think this issue is a very important one. Teresa, I don't know if you want to speak to that.
Just to reiterate that it's very important to get 2 doses to maximize protection. And I think provinces are, you know, at the moment going back to vaccinate those initial high-risk groups. So you'll see that happening. And many of the long-term care facilities have already had 2 doses. But what I do know from a supply perspective is that given the age group and the amount of vaccine that is needed in the younger age group, what I've been told is that you can actually do both because of so much vaccines arriving. You can do both simultaneously.
I have to say that I'm happy to hear that, knowing that my grandchildren will be getting their vaccines next week. My next question is to Mr. Vignette, and I'm sure that the pre-pandemic CBSA officers at the border were used to processing much higher levels of passengers and cargo on a daily basis. And with the pandemic, I'm sure the nature of the job has changed. Can you share with us a bit about how there's been a different training for CBSA officers, what they've gone through to adapt, as well as what's being done to ensure their safety as they continue to do their jobs?
Yes, thank you, Chair and member for the question. I must say that right from the onset of our preparation and response at the border, our officers' personal health and the performance of their duties on a day-to-day basis took front and center in all of our preparation. Everything from making sure that they had sufficient personal protection equipment, and since that time, we've moved into providing shelter from some of the travelers using plexiglass. We've instituted sanitization chambers so that their tools can all be sanitized at the end of their workday. And so it's been an ongoing effort to ensure their safety. As for some of the how the work has changed, I must say that commercially, the truck traffic and the commercial cargo entering the country has actually surpassed pre-pandemic levels. And so we've been successful in ensuring that economic activity and trade has continued throughout the pandemic, notwithstanding there was an immediate lull through the March to June period of last year. As it pertains to dealing with travelers, clearly we've trained them on the understanding of the new legislation as it passed under the OICs for its application. We've continued to support them in many ways. They have 724 access now to our border task force that provides them policy advice on the application. And we've ensured that they have all of the latest in terms of what is transpiring as their work has shifted. They've been briefed by the local health authorities in terms of, certainly at the onset, what was COVID, what protections could they take, so that they could continue to come through to and report to work. Extremely proud of the professionalism of the men and women of the CBSA and all frontline workers who've continued to come to work on a daily basis, making sure that the borders were secure.
Thank you. Back to Dr. Tam. It's encouraging to see that Canadians are getting vaccinated in such high numbers, and I hope this trend continues until everyone's vaccinated. But what does this uptake tell you about the confidence that Canadians have in vaccinations?
Well, I think it's very encouraging. And of course, with the groups at the highest risk and seniors, the uptake has been really remarkable and in long-term care. So I think it's to keep it up. The latest surveys indicate that the vast majority of Canadians, over 80% for sure, wants to get vaccinated or have already been vaccinated with at least one dose. Once you get one dose on board, the key is to keep up with making sure people remember to get the second dose. But I do think that we could do more work in making sure that the younger adults at this point and the younger youth also pick up on that momentum. But it is extremely encouraging at this point.
Thank you, Mr. Van Bynen.
Thank you.
Nous allons maintenant.
We now go to Mr. Thériault. Mr. Thériault, go ahead, please. 2.5 minutes. Thank you, Mr. Chair. In a document from the Government of Canada on vaccines against COVID-19, shipping and delivery, as of May 11th, 2.3 million doses of AstraZeneca were distributed in Canada. Nothing from Janssen. So Quebec and some provinces have already indicated that they would limit their use of AstraZeneca for the first dose because of safety problems and supply problems. So regarding agreements, the federal government with vaccine makers, there's 20 million AstraZeneca doses and up to 38 million doses of Janssen. Is the federal government responsible for all of the doses obtained despite the problems with safety and production? And do the agreements have provisions for canceling these orders without financial penalties?
Merci, Monsieur le Président.
Thank you, Mr. Chair, for the question. I can begin. 1 second, please. Thank you. Just to begin, all contracts have clauses to allow Canada to give doses to other countries. That's always an option. Almost all of the contracts have clauses.
Your mic a little bit.
Est-ce que c'est mieux? Is that better? Mes excuses. So we have in place clauses that allow Canada to donate, as well as to exercise options if more doses are allowed. I would maybe underline for the members that when these contracts were negotiated, it was uncertain whether the vaccines would work against COVID, and also whether there would be any production challenges along with those things. So very uncertain timelines. So if the question is, can Canada just arbitrarily decide to opt out of the doses they have committed to? The answer is no.
La réponse est non.
The answer is no. The answer is no, but we can adjust the timeline to get the doses next year, the year after. But can we cancel a contract?
When you're referring to AstraZeneca, it is a vaccine approved by Health Canada from a regulatory perspective, so it's met that test, and that's really all I can offer at this stage.
Donc, il n'y a aucune clause.
So there's no clause in the contract that would allow us to not face all of the financial penalties if we were to say this vaccine has risks and we have decided not to use it. You've said we'll buy it and send it elsewhere. So everything that's been reserved, you have to pay for it. Is that correct? Yes. And as I've mentioned already, Mr. Chair, Canada can donate doses to other countries. That's always an option. Thank you, Mr. Tedio.
We'll go now to Mr. Davies. Mr. Davies, go ahead, please. 2.5 minutes.
Thank you. Dr. Tam, you've said on a number of occasions on a global basis that no one is safe until everyone is safe. The World Health Organization is urging wealthy countries like Canada to delay plans to vaccinate low-risk people like children and instead donate available doses to the COVAX facility to provide vaccine access to high-risk populations in low-income countries. In your view, should Canada comply with that request? And if not, why not?
So, Mr. Chair, that is a very, very important underlying principle, and I think global policy on vaccine equity. So, absolutely, I support the need to ensure vaccine equity. I know that our decision makers have difficult decisions to make, and but for sure, making sure Canadians get the doses that they need. But at the same time, supporting COVAX with the significant investments. And I do know that discussions are very much live on what we should do as a next step in terms of COVAX and donations.
Thank you. Mr. Stewart, who in government is responsible for quarterbacking the delivery of documents to this committee that were ordered by the House of Commons last October? Sorry, you're muted.
Thank you, member. You mean the House motion
Yes.
for the production? Dr. Lucas is probably best placed to speak to the overall portfolio response in that regard.
So thank you, Dr. Lucas. The clerk of the Privy Council, Ian Shugart, put in writing to this committee that there were over 1 million documents. To date, that's going on 7 months, this committee has received about 8,000. That's about 992,000 documents that have yet to be delivered. Is the government purposefully delaying delivery of documents to this committee, given that they don't have to do any redacting but are supposed to deliver all those documents unredacted to the law clerk?
Mr. Chair, in response to the first part of the question, the organization and government responsible for the overall coordination is the Privy Council office. Within the health portfolio, we have worked to gather up documents and have provided them. Further review continues on legal or personal information to at least be able to identify those sections. And that work continues with provision of documents on an ongoing basis through the Privy Council office and the law clerk.
Thank you, Mr. Davies. We'll start round 5 now with Ms. Rumpel-Garner. Please go ahead, please. 5 minutes.
Thank you, Chair. I just wanted to clarify with Mr. Matthews the response given to my colleague, Mr. Terrio's questions. So the contracts that we have with AstraZeneca do not allow Canada to cancel the contract.
So, Mr. Chair, just to clarify, when these contracts were negotiated, these suppliers were effectively experimenting and manufacturing at risk. So when you sign on for doses, well, we have the right to donate. These doses met the regulatory test, so they are Canada's to do with what we choose.
So there's no opt-out clause?
There's opt-out clauses in terms of options, but in terms of the actual initial commitment around doses, they are doses that Canada signed on for.
Is that the same with all of the contracts we've executed?
I'm going from memory here. Generally speaking, these were very much at-risk contracts. So the vaccine producers were not interested effectively in allowing for opt-out clauses because they are taking all the risk in terms of the research, the clinical trials, and then the eventual production. So when you sign on for doses, you are making that commitment.
Okay. To I guess, Dr. Tunis, on what date will the NACI report on second doses for persons who have received the first dose with AstraZeneca be released?
Thank you for the question. It's impossible to provide an exact date because the committee's deliberations are contingent on scientific evidence coming out of the mixed schedule studies in the UK. So depending on the progress of that research, then the committee will be timing their advice very shortly after that. So we do anticipate.
Ballpark?
Yeah, we do anticipate in the first 2 weeks of June, and the committee is very committed to doing this as quickly as possible, understanding the need for provinces and territories to design their programs around this.
Okay, thank you. I guess this would either be to procurement or PHAC, I'm not sure. How many doses of Moderna are we expecting in the months of June and July?
Maybe I can start and Ian can chime in. So Moderna becomes the workhorse of the portfolio in Q3. There's a big Q3 ramp up. We are waiting for a revised schedule from Moderna because I think it's been well documented. Moderna's hit a bit of a bump on production. So we should have clarity on what the schedule looks like for June and July in the next week or so. So I apologize, Mr. Chair, I can't give you a firm number on expectations for Moderna in total in June and July, but we should have a better sense after next week.
We know that Moderna has prioritized delivering doses to EU countries. Mr. Matthews, has the government directed you to look at any options for legal recourse given the delays and clarity for delivery from Moderna?
Mr. Chair, it's not clear to me that Moderna has prioritized for EU countries. They've, as I mentioned, hit some challenges and they are trying to best serve, the various contracts in the best way possible. So over 1 million doses arrived this week. We're optimistic that we will get the next shipment of Moderna the first week of June. But as I said, Mr. Chair, we'll have to wait on further details for what June and July look like.
Dr. Tam, in a response to a question from one of my colleagues, you cited data saying that approximately 80% of Canadians were open to receiving a vaccine. Are you or your agency assuming about a 20% hesitancy rate in Canada then?
With the rest of the 20%, there are some who are questioning and wanted to know more. But I think there's maybe around 12 to 13% of those who are essentially against taking the vaccine. And so I think that 20% is heterogeneous. But I would have to say that even with good vaccine confidence, we mustn't be complacent for sure in terms of our efforts.
So we're assuming about an 80% uptake rate in Canada, roughly.
We don't know for sure, but it's looking quite good from that perspective.
Thank you. Last question. I'll go back to Mr. Stewart. Just to be perfectly clear, as of today, if a Canadian crosses the border to get vaccinated in the US, even with appropriate documentation, they would still have to quarantine upon re-entering to Canada.
My colleague John Osowski could speak more definitively than I can, but my understanding is the U.S. would not admit them if that was the purpose.
Well, there are Canadians who can enter the U.S. legally and could do this. So if somebody was allowed access into the U.S. to get vaccinated, they would have to quarantine upon return.
So they've now made a trip into the U.S. They would come back and they would be subject to quarantine and testing.
Are there any plans to change this?
For people to go south of the border and get a vaccine and then come back across?
Without quarantining.
Is there any change to change? No, there is no plan to change that.
Thank you.
Thank you, Ms. Rumpel-Garner. We'll go now to Mr. Kellaway. Mr. Kellaway, go ahead, please. 5 minutes.
Thank you, Mr. Chair. Just a slight issue here, but my question will be for either Dr. Tam or Dr. Tunis, or actually both. Yesterday, actually, all of my staff in the span of the last 5 days received their first COVID-19 vaccine here in Cape Breton. And we've talked about it here in terms of vaccine and vaccination numbers increasing across the country. So I'm wondering if you give the committee a sense of the benchmark you're looking at in terms of Canadians getting vaccinated before we can turn to some sense of normalcy. And are you hopeful that the Canadians will reach that level? Thank you.
Mr. Chair, I thank the member for this question. We've used dynamic modeling to try and get at looking at some of those scenarios. So what the model that I had presented publicly, the scenario is that if you have at least 75% of Canadians getting the first dose, and we were at that time looking at adults 18 years of age and over, as well as 20% getting the second dose. At that time, if we lifted, well, that would be up to the provinces, of course, lifted more restrictive measures, then we won't have as much of a risk at overwhelming our health system or hospitalization. So that was one benchmark. The second benchmark would be to have 75% of Canadians getting both doses. And at that point, we're looking towards a hopeful full season when people can get back inside and have a reduced risk of transmission, and getting towards those things that we miss quite a lot. And so we're looking forward to universities, schools, and other of those social settings getting back to towards normal without overwhelming the health system. And so that was a benchmark. So since then, the provinces and territories, many of them have come out with their reopening approaches. And I think that some of the provinces have indicated certain targets which are in that kind of ballpark, but they also take into account the infection rates in their own province as well. So they may go higher or lower depending on how much of the population might already, for example, have encountered the virus itself. So you'll see a bit of shift in those depending on the jurisdiction, but roughly around that kind of ballpark.
Very good. And Dr. Tunis, do you have anything to add to that, or anything that you would want to comment on?
I would only add that that NACI is also considering the same evidence, and that they are generally supportive of what Dr. Tam just said. Thank you.
Thank you, Doctor. Chair, how much time do I have left?
You have 2 minutes left.
Wonderful. My next question, I'll stay with Dr. Tam. So last week, Nova Scotia, along with several other provinces, paused administration on the AstraZeneca vaccine, as we all know. In Nova Scotia, my understanding was primarily due to the shortage of the vaccine. But we know that it is still safe and an effective vaccine in terms of preventing the spread of the virus. However, I have had a lot of constituents concerned about their second dose, quite frankly, and they feel as though they're in limbo. And these are through calls and through emails. But I believe there has been some recent international studies on mixed vaccination doses, such as the reports that were released in the UK, I believe, and in Spain. So can you tell the committee what Canada learned from these studies? And I know we touched upon it here, but maybe this is an opportunity to do a little bit of a deeper dive in terms of the answer. Thank you.
So, Mr. Chair, I'll answer the question in a couple of parts. One is that there shouldn't be a concern about supply itself. We do know that there are supplies of AstraZeneca vaccine. Should the second dose be using AstraZeneca? But the more important point is the last part of the question, which is I think the international data is looking quite promising towards the effectiveness and safety of a mixed schedule. So a mRNA vaccine, for example, following the AstraZeneca vaccine. So I am optimistic that there's in fact a option there. But again, it would await the NACI examination of that data. as per Dr. Tunis's timeline that he expressed. So I think I just want to acknowledge that it is, of course, anxiety provoking, and that's understandable. But for those who've received that first dose, that answer will be available within the time frame that is a reasonable time frame for the timing of that second dose.
Thank you, Dr. Tam and Dr. Tunis. That's all from me, Chair.
Thank you, Mr. Kellaway. We'll go now to Mr. Barlow. Mr. Barlow, go ahead, please. 5 minutes.
Thank you very much, Mr. Chair. And just to follow up on the previous questions from my colleague, then what you're saying, is there a strategy, maybe to Mr. Stewart, is there a strategy to end the hotel quarantines based on the benchmarks that you previously mentioned?
At this time, there is not a strategy to end the government-approved accommodations.
But you did say that you were using some benchmarks to set these criteria or set these timelines. So if you're using these benchmarks, then why would there not be a plan to end the hotel quarantines?
Mr. Chair and Honourable Member, thank you for the question. You are absolutely right. We are tracking indicators such as the infection rates in the local population, as well as the infection rates of people coming across air and land borders, and we're maintaining that quite closely. At this time, there is not a strategy, though, to answer your question, to make a change of that nature.
So there's no plan to end these hotel quarantines. So is it safe to say that these are simply a means to deter travel, and that's really the only basis that you have no data that tells me that it curbs the spread of the virus any more than quarantining at home, and there's no plan to end the hotel quarantine. So is this just a means to deter travel?
I don't agree with those statements, Mr. Chair and Honourable Member. There is a public health benefit, and the public health benefit I've mentioned earlier in today's proceedings is to stop people from arriving internationally and then getting on to domestic flights while they're in an infected state. And I also mentioned earlier that the number of people arriving at airports are substantially higher and more likely to be infected than at the land border. And those are the motivating factors behind the government-approved accommodations.
I understand what you're saying, Mr. Stewart, but I did ask you earlier and several occasions in the past, then how come you haven't tabled the data that shows that this is working? And again, today I've asked that, and you're just saying this is why you're doing it, but there's no plan to end these. And we have, approved quarantine hotels are accepting quarantine bookings well to the end of September. So when you say that you're hoping to have everyone vaccinated by September, why are hotel quarantines going to be in place until the end of September?
Our positivity data, the testing data is on our website, I believe, Mr. Chair and Honourable Member. We do track that, and we do try to make that information available. We look forward to continuing this discussion as the summer progresses and the vaccination progresses. Hopefully it will provide us opportunities to make adjustments of the nature you're describing.
Just to move on to the contracts, and I know my colleagues have mentioned the fact that there's no opt-out clause. But is procurement actively negotiating transparency clauses in future or amended contracts related to the COVID vaccines, which would allow for parliamentary oversight, similar to what the UK has been able to secure?
A couple of comments to make on this, Mr. Chair. We are negotiating for 2022 and beyond, and we've had some work done there already. There are considerations here in terms of additional transparency, and we're working through right now with our suppliers what transparency might look like. This is an industry that's very interested in protecting its own interests, and I do have to say that we have to protect Canada's interests as well in terms of future negotiating. So we're trying to strike that fine balance, and the discussion continues.
Well, to that, Mr. Matthews, then, if you're looking to improve transparency in this round of contract negotiations, why wasn't that transparency part of the negotiations in the original contract negotiations, as this committee has put a motion forward, unanimously supported, to have access to those vaccine contracts, which we still have not seen? There was an order in the House of Commons last October asking for these documents. We still have not seen those contracts. So why now is transparency an issue, but it wasn't previously, and still doesn't seem to be an issue for this committee?
I think a couple of points here, especially early on, Mr. Chair, a year ago when we were negotiating these. the suppliers are very much as a non-starter, frankly, when we talked about transparency. And we did, we do have some ongoing discussions about what can be released and what cannot be released. Hopefully we have documents for the committee in the next 2 weeks or so. We are getting close to answering that question, but it is a two-way street here. The government does want to protect its own interest for future negotiations, and the industry wants to protect its interests. And I will say broader industries are watching how this plays out. We've heard from numerous industry associations, especially around the military and defense type industry, who are very, I guess, want to underscore the importance of Canada protecting commercially confidential information for industry. So everyone's watching this discussion, and I do appreciate it's taken longer maybe than members would have liked, but we are closing in on it.
Thank you. And maybe to CBSA, I know we've talked about opening the border, and I think Mr. Pawlowski and many others like myself who have border ridings. But is there any, has CBSA had any direction from the government in terms of a definitive criteria needed to support the opening of the Canada-US border? Is there a specific criteria or checklist that has to be met before we can open that border?
Well, thank you for the question, Chair. So certainly we would rely on whatever the scientific advice is from our colleagues in Health Canada and FAC. So understanding the epidemiology, understanding the healthcare capacity in local areas, because it can vary.
Sorry, this is my last the time.
Thank you, Mr. Barlow.
Does that criteria exist? Yes or no?
We have a certain set of criteria that we have started to work with, but it's an evolving thing.
Right
and
thank you.
Yeah. Thank you, Ms. Barlow. Go now to Ms. O'Connell. Ms. O'Connell, please go ahead. 5 minutes.
Thank you, Mr. Chair. I think the Conservative leader might be surprised with some of this line of questioning, because on social media, he seems to indicate that border measures need to be stronger, but then here in committee, Conservative members argue to actually loosen those border measures that are in place to keep Canadians safe and stopping the spread. So there might be a disconnect within the Conservative Party right now. That's unfortunate. Mr. Stewart, I want to talk about those questions a little bit about the vaccine, crossing the border to get the vaccines. So correct me if I'm wrong. I'm going to lay out a little bit of a scenario. So if a Canadian wants to cross the border to get a vaccine, that requires more contacts, presumably, than, let's say, if they were to book an appointment locally, go to that pharmacy or facility to get the vaccine, then go home, versus crossing the border, whether by land or air, would have many more contacts. And then this notion that there wouldn't be a quarantine requirement if they were even able to gain entry into the US, which the US has indicated this is not an essential medical service. But notwithstanding that, if they did cross that border, the argument to remove any quarantine measures, I don't understand how that makes any sense, given the fact that even when I went for my vaccine, or when my parents got their initial vaccine, they were told that vaccines don't become immediate. They're not immediate protection. And Dr. Tunis even talked about, there are studies talking about the length of time for your body to build up those antibodies or immunity, or the antibodies against the virus. So the notion that the second you get this vaccine, therefore you're protected and not going to put anybody at risk, and therefore don't require testing or quarantining. Do I understand that correctly, that it's actually you're at risk because you now come into contact presumably with more people than going locally, and secondly, you're not immediately immune, and therefore not quarantining and not testing, you could actually unknowingly be putting even more community spread out there?
Mr. Chair and Honourable Member, you have it absolutely right, actually. And that is the reason why they would come back and do testing and quarantine, because it usually takes about 14 days, and Dr. Tam can speak more authoritatively than I can, for our body to mount its immune response after vaccination. So they, in effect, are not yet benefiting from that vaccine by way of protection. So yes, you're quite right.
Thank you. And then just on the AstraZeneca piece, while we were in this meeting, I think Ontario announced their second dose strategy. And in fact, I was already getting messages from friends excited that they've booked their parents for their second dose of AstraZeneca. I guess this might be a question to Mr. Stewart or to Mr. Matthews in terms of procurement. We don't quite know how many people yet will want to receive their second dose. Frankly, some are not eligible yet just based on timing, and it's ultimately up to the provinces and territories to determine that schedule. But are we actively monitoring the uptake for second dose AstraZeneca? And are we working with provinces and territories to make sure that if there is additional needs, whether it's AstraZeneca or let's say a Pfizer vaccine, to make sure that those Canadians still have access to a safe second dose? And if we are, I guess the question is, are we confident and comfortable that this momentum of vaccines coming to Canada is going to continue and we're still going to meet those targets?
Mr. Chair and honorable member, thank you for the question. First of all, I just want to note I'm a one-dose AstraZeneca person, and I'm looking forward to a second dose like many other people are. In that regard, as I mentioned, we have 655,000 additional doses being distributed in real time. That will cover all of the demand for people's timelines for their second doses all the way through June. And as Bill Matthews can speak to, we have other sources of supply lined up in the event there is a desire by the majority of people to continue with a second dose. As Dr. Tunis was setting out, however, we're also going to have the optionality, quite likely, it's not yet substantiated by way of the data, that people could get a second dose of messenger RNA. So I think everybody who's waiting for their second dose from a first dose AstraZeneca perspective is well looked after. There is supply, we have it now, and we will have, in fact, further options in addition to what's required over the course of the coming weeks. I don't know, Bill, if you want to add anything on the supply side.
The only thing I would add, thank you, Ian, Mr. Chair, is that next shipment of AstraZeneca, should it be necessary, you're likely looking last week of June, and we'll play that by ear based on demand from the provinces. And we do have enough Pfizer and Moderna on order in case people are interested in getting a second dose of that instead of AstraZeneca, should that be the health guidance. So I feel like we're covered either way.
Thank you.
Thank you, Ms. O'Connell. We go now, nous allons maintenant à Monsieur Thériault. Monsieur Thériault.
We go now to Mr. Thériault. Mr. Thériault, 2.5 minutes. Thank you, Mr. Chair. My question is for Mr. Vinette. The reopening of a border, like the Canadian-American border, is not something that can be just improvised. I imagine that you've been reflecting on a reopening plan for non-essential traffic. 34% have the first dose, so there's still a ways to go. The Prime Minister has said that public health measures would be lifted when 75% of people have received a first dose. Is 75% part of your criteria for planning? Can you tell me about what your plans are? How will you proceed? Thank you, Mr. Chair, for the question, and thank you to the member. Since the beginning of the measures at the border with the United States, we've been laying the groundwork for the eventual reopening. We've been assessing projections for the volume. We're checking our capacity with Transport Canada. The interpreter would like to note that the sound is intermittent. So we're looking at what measures we can take to reopen the border in a measured, well-managed way. And we're in discussions with our American counterparts to note that we're on the same page. So regarding vaccines and vaccination rates, that's an element that would certainly be considered, and that will be led by the Public Health Agency of Canada and people who are looking at the science in that area. During a worldwide pandemic, reopening a border like this one requires planning that must be very rigorous. In your scenarios, do you think it would be done by segments, by area, or would it be done nationally? Do you think you'd be waiting until the situation is stable from coast to coast? Are you looking at those different scenarios? Are you having those types of discussions? Yes, absolutely. We're in contact with our partners, the Five Eyes, England, New Zealand, Australia, the United States, so we can learn from their experience to inform our approach. And currently, we are developing different scenarios to inform our approach to reopening the border, and whether it's in terms of doing it by segments or nationally. So it's all informed by medical science, if you will. And we're taking our guidelines from the Public Health Agency of Canada. Do you have the information you need now for a safe reopening? Thank you, Mr. Thériault.
Monsieur le Président.
Mr. Chair, please. Some others have had a bit more time. It's an interesting question, Mr. Chair. I was asking if he had the information. Mr. Thériault? Yes, Mr. Chair. I saw earlier, Mr. Chair, that your card was up and it went down when it was Ms. O'Connell. And now that it's my turn, you give me 2.5 minutes, but the Liberal Party has tons of time to ask its questions. We'll be discussing this later, Mr. Chair.
You've had 4 minutes. Your time is up. Mr. Davies, go ahead, please. 2.5 minutes.
Well, I look forward to my 4 minutes then, Mr. Chair. Mr. Stewart, what percentage of people arriving from international air flights end up in quarantine hotels?
We have that statistic, and if I have a minute, I can provide that. If not, we'll follow up with you in writing after the proceedings, sir.
Thank you. Now, if Alberta, the province, is not enforcing federal hotel quarantine rules, why doesn't the federal government, which controls airports, simply take away their right to receive international travelers and transfer it to a province who will enforce those rules?
Mr. Chair and honorable member, that's a question that's larger perhaps and touching on many factors other than just my responsibilities at the Public Health Agency.
Okay, thank you. In her very first news conference since assuming command of PHAC's vaccine rollout, Brigadier General Brody announced that Canada will receive 8 to 10 million fewer vaccine doses than originally expected by the end of June because of delays with shipments from Moderna. Will this shortfall force the provinces and territories to cancel or postpone vaccine appointments that have already been booked?
Mr. Chair and honorable member, the media characterization of the comments that she made was the way you've just portrayed. Actually, what Brigadier General Brody does is speak to what is confirmed by way of shipments versus what Bill Matthews, who's here with us, would talk about regarding what's expected by quarter. And perhaps he could speak to that delta.
Thank you, Ian, and Mr. Chair, I'll be very quick here on this front. Ian is bang on in terms of what Madam Brody spoke to. The question mark is what will Moderna deliver in June? And as I mentioned in response to a previous question, we will have clarity on that in the next week or so. And we're happy to share that, but that was the delta that was being referred to. And as I mentioned, we're hoping for a shipment of Moderna the first week of June, but we'll be looking to firm that up shortly.
Thanks. The COVAX facility recently announced it has a supply shortage of at least 140 million doses, in part because of the ongoing COVID crisis in India. The WHO, UNICEF, and other international agencies have called on G7 countries to donate excess supplies. We know the US, France, and Sweden have announced plans to donate tens of millions of doses in the coming weeks, and Canada is yet to make an announcement. Instead, we continue to draw doses from COVAX. Does Canada need to draw on supply from COVAX to offer a second dose of the AstraZeneca vaccine to Canadians who received it as their first shot? And do we intend to donate any AstraZeneca vaccines not needed for second doses to the COVAX facility, and when?
Mr. Chair and Honourable Member, thank you for the question. As you'll remember, earlier in this year, we had many meetings where we were under intense pressure to get the number of vaccines out there, and we had strategies to acquire vaccines for a portfolio-style approach. Now that we are getting further along in our immunization program, as you point out, there are opportunities to make choices. So there's nothing for us to say at that topic at this time, but that's an active topic of discussion. So thank you for the question, sir.
Thank you. Dr. Tam, is the guidance that the government giving to Canadians still to take the first vaccine offered to them?
I think the advice is that every Canadian who is going for vaccination will be provided with what the province determines as the appropriate program. But every Canadian should have the ability to have informed consent. And as part of that, I think what you might be trying to point out is that there are some differences between vaccines and recommendations pertaining to age groups, for example, or people with other contraindications, for example, and that is done through an informed consent process. And you will see the provinces, including that of Ontario, as they're providing that second dose to people who've received the AstraZeneca vaccine, that is very much part of their process, is informed consent.
Thank you, Mr. Davies. So that wraps up our round 5. We have 4 minutes left. I propose that we do a lightning round with 1 minute slots per party. If that's acceptable to the committee, we'll go ahead with, I believe it's Mr. Barlow to begin.
Thank you, Mr. Chair. And to Mr. Osowski, just to finish up on my previous question, you said there's no criteria in place. How are we negotiating the safe reopening of the border with the United States? We have no benchmarks or criteria in place. Canadians need hope. We don't need any more cute one-shot summer hashtags. We need hope. When will the criteria be in place to safely reopen the border and end hotel quarantines?
So we're actively working with those criteria, as I was starting to talk about before. So the epidemiological curve, the healthcare capacity, my officer capacity, the processes in terms of what will be required to be undertaken, because obviously we're asking a lot more questions now of folks as they're coming in the country either by air or land than we were before. So there's transaction time considerations. So there's
when do you think that will, I only have a minute, sorry. When do you think that will, again, the frustration that we're all hearing is palpable. When do you think that criteria and those benchmarks will be in place so those discussions can start to happen? We see a path to reopening the border and ending these hotel quarantines. When do you think
that'll be? Dr. Tam has already expressed the broad criteria here of what we're looking for in terms of the safety, and that would be the first point that we would be looking for, and then the subsequent measures that I talked about.
So you don't know. There's no plan. Yeah.
Thank you, Mr. Barlow.
Thank you, Mr. Chair. Yeah.
Go now to Dr. Pawlowski. Go ahead, please. 1 minute, sir.
My guess is that all of us on this call are like the majority of adult Canadians. We've had 1 dose, but not our second dose. And my understanding is now Canada is ahead of the United States in terms of getting out the first dose. I know that because Ron MacLean said it on the hockey game last night, and I get all my medical information from Ron MacLean in the hockey games. So now, what does it? And my question to Dr. Tam: what does this practically mean? I know I was discussing with an infectious disease colleague yesterday, and he said he's seen quite a few people in the ICU who've had their first dose. On the other hand, the evidence is really pretty good. That 1 dose provides a great deal of protection. But what does having 1 dose practically mean in terms of what we can and can't do in terms of social distancing? Thanks.
Thank you. And I won't go back to look at the modeling or those criteria for safe lifting, but really the concept is as communities, as the populations, we need to get the vaccine coverage up. With 1 dose, and that's why we pointed to making sure still that people are vigilant is that one dose gives you good protection, but you should get that second dose for maximizing that protection and durability. And in the meantime, you should take all the precautions and follow local public health advice. Don't let your guard down and don't go halfway with your vaccine schedule. And so, which is why this is a prudent precautionary approach. And I think we should have our eye on the puck, as it were, as we skate towards that 2-dose for everyone in Canada.
Thank you, Dr. Pawlowski. We go now to, nous allons maintenant Monsieur Thériault.
We go now to Mr. Thériault. Go ahead, please, 1 minute. Mr. Vinette, since the first wave, has the agency increased its staffing? And does it plan to increase staffing to ensure the reopening is done safely at the border? Thank you for the question. Yes, we haven't stopped hiring employees, frontline officers, about 300 per year. We do it at our college in Rigaud. We've reallocated staff because of a reduction in trips by individuals. We've put them in our commercial operations. And we're also doing maritime and air checks because of the pandemic. So part of planning is to bring those people back to the front line and to continue to graduate people from our college in Rigaud and to put them at the border. How long does it take to train someone? It's a 16-week course followed by inaudible for the interpreter. So training on the ground for 12 months. 16 weeks in Rigaud at the National College, and then training continues on the job for another 12 months. Thank you. Thank you, Mr. Thériault.
Now to Mr. Davies. Mr. Davies, go ahead, please. 1 minute.
Thank you. Well, I was just checking numbers on the U.S., and as of May 19th, the U.S. has vaccinated 60% of Americans with 1 dose, and 37% have received 2 doses. And I'm just wondering, with this sort of self-congratulations of the government patting itself on the back for finally getting first doses up, that they're winning a race that nobody else is running in. Obviously, the United States at 37% of full vaccinations, the UK at 31% of full vaccinations, the EU even at 16% of full vaccinations versus Canada's 3%, means that the US has got 13 times the number of people fully vaccinated. The UK is 10 times the number of people fully vaccinated, the EU 5 times. And I'm just wondering, it appears to me that you'd almost think that we did this deliberately, that we decided we'd go for one vaccine because it was the best epidemiological approach, instead of the truth, which is that we did it because we had a shortage of vaccines. So I'm just wondering, considering the EU, the UK, and the US have all proceeded with a full vaccination strategy, Dr. Tam, can you tell me, is it not better to have more of our population fully vaccinated than not?
So, Chair, thank you for that question. And as I've said, we should have everybody getting 2 doses. I do think that the stretch interval has been an extremely good strategy. The UK has done the same, by the way, and have seen very good results. And it's their study, I was just going to bring it up from the recess of my memory, is that, in fact, if you stretch the Pfizer vaccine dose for even seniors, 80 years of age and over, they actually have a greater antibody response at that 12-week compared to 3 weeks. So I don't think it's not a, as you said, I totally agree, it's not like a race with other countries. We need to take care of Canada, and all Canadians should get that 2-dose vaccine. And we will look towards a much more hopeful and optimistic summer and fall.
Thank you, Mr. Davies. So thank you to all the witnesses for appearing here today to help us with our inquiries. And thank you also for your ongoing 24/7 dedication and commitment to the health and safety of Canadians. And thank you to the committee for all of your great questions. It's good information. So with that, we are now adjourned. Thank you.